very good morning to all the seniors, the teachers from whom we learn so many things. Today we will start the program Pronam. I am very grateful to be a part of this program. We will start the program now, and I am handing the mic to the Arup Bhomik sir.
গুড মর্নিং সুপ্রভাত, আমি বাংলায় বলছি। এটা ওয়েস্ট বেঙ্গল অপথলমোলজিক্যাল সোসাইটির তরফ থেকে এটা দ্বিতীয় প্রয়াস, দ্বিতীয়বারের মতো হওয়া প্রণাম শুরু হয়েছিল 2-3 বছর আগে। যে আমাদের যারা টিচার আমাদের এত এই জায়গায় আমাদের ওয়েস্ট বেঙ্গল অপথলমোলজিকে নিয়ে এসছেন, যার জন্য আমরা এত ভালো এখন কাজ করছি, তাদের শ্রদ্ধা জ্ঞাপনের জন্য এই প্রোগ্রাম শুরু করা। তো এই প্রোগ্রাম যে কনসেপচুয়ালাইজ করেছেন সেটা হচ্ছে আমাদের প্রিভিয়াস সেক্রেটারি ডক্টর সুভাষিস নাগ, অ্যান্ড আমি আমাদের এখন প্রেজেন্ট সেক্রেটারি ডক্টর দেবাশিস দাসকে আমি ইনভাইট করছি কিছু বলার জন্য এই প্রোগ্রাম নিয়ে।
Good morning, everybody. This is our honor. এটা আমাদের কাছে একটা সম্মানের ব্যাপার যে আমরা আমাদের সিনিয়র যারা এতদিন ধরে সোসাইটিটাকে ধরে রেখেছেন, সোসাইটিটাকে নিয়ে গিয়েছেন, তাদেরকে আজকে আমরা সেই সম্মানটা জানাচ্ছি। এই সম্মান জানানোর এই অনুষ্ঠানটি প্রণাম, এর আগে আমরা এটা করেছি হায়াতে, আজকে সেটারই দ্বিতীয় সংস্করণ। প্রণাম আমাদের বেসিক্যালি সমস্ত সিনিয়রদের 70 যারা আজকে, তাদেরকে আমরা আজকে অভিবাদন করব একটি মেমেন্টো আর আমাদের তরফ থেকে একটু ফুলের ইয়ে দিয়ে। এই নিয়ে আমাদের সেই সঙ্গে আমরা একটুখানি ব্যাকগ্রাউন্ডে যাব, অপথলমোলজি আগে কিভাবে হতো, এখন কিভাবে হচ্ছে। আগে আমাদের অপথলমোলজি পড়াশোনা কিভাবে হতো, এখন কিভাবে হচ্ছে। আজকে অ্যাকাডেমিক্সের মধ্যে না গিয়ে এইগুলো নিয়ে একটু প্রাথমিক চর্চা আছে, এবং পরবর্তীকালে সকলের মনোরঞ্জনের জন্য আমরা একটি হাসির নাটক করব ছুটির ফাঁদে। এই ছুটির ফাঁদে নাটকেও আমরা আমাদের সিনিয়রদের সঙ্গে নিয়ে কাজ করছি, এবং আশা করি এই নাটকটিও আপনাদের সকলের মনোগ্রাহী হয়ে উঠবে। সেই নিয়ে আজকে এখানে শুরু করছি। শুরু করার আগে আমি আমার প্রেসিডেন্টকে স্টেজে নিমন্ত্রণ করব, আমি ওনাকে আমাদের প্রেসিডেন্সিয়াল মেডেলটা দেব। ডক্টর দেবদাস মুখার্জি, প্লিজ। May I request our President, Dr. Devdas Mukherjee, to speak a few words, please.
Good morning. It is a nice occasion to be here. It is a pranam to every one of my teachers, যারা আমাকে হাত ধরে চলতে শিখিয়েছে, যাদেরকে ছাড়া আমি হতাম না বা আমরা হতাম না। তাদেরকে প্রণাম জানাবার যে অবকাশ পেয়েছে এবং আমার প্রেসিডেন্সিয়াল সময়ে যাদেরকে পাচ্ছি, তাদের প্রতি আমার আন্তরিক শ্রদ্ধা এবং প্রণাম। বয়স আমার আর 2-3 বছর বাদে হয়তো আমি রিসিভ করতে যাব আর কি, কিন্তু 68 বছর বয়সে আই এম স্টিল এ স্টুডেন্ট। আই এম লার্নিং ফ্রম এভরিওয়ান। সুতরাং ইট ইজ এ কন্টিনিউয়াম, এটা কোনো একটা সিঙ্গল ডট ইন টাইম নয়, এটা অনেক দিন ধরেই চলছে এবং আমরা প্রত্যেকেই শিখছি। এবং যাদের কাছ থেকে আমরা শিখেছি করে আমরা নিজেরা তিলোত্তমা কিংবা মা দুর্গা হয়েছি, যাদের কোনো নিজস্ব কোনো এক্সিস্টেন্স নেই, আনলেস উই আর বেস্টড উইথ দ্য বেস্ট ওয়েপন্স ফ্রম আওয়ার টিচার্স। আমি তাদের কাছে শ্রদ্ধা জানাতে পেরে আমি নিজেকে ধন্য মনে করছি। ধন্যবাদ।
We will start our first session with some academics. I hand the mic to Dr. Anuradha. She will moderate the session.
Pronam to all my seniors and my teachers. Starting the session with evolution in ophthalmology, I would please invite the chairpersons, Dr. Mohammad Yasin sir, Dr. Pradeep Bakshi sir, Dr. Arup Chakraborty sir, and Dr. Rotish Chandropal sir, please on the dais. I would invite our first speaker, Dr. Shuchandra Shaw, who will be telling us how glaucoma has evolved over the years.
Good morning, সবাইকে, and pranam and respect to all my seniors, teachers, and warm regards to my colleagues. আজকে সত্যি to be a part of this program is a privilege. Thank you, Rupak. Thank you, OSWB. টপিকটাকে একটু চেঞ্জ করা হয়েছিল রূপকের সঙ্গে কথা বলে, যে গ্লকোমা বলতে গেলে there would be a lot of things to talk about. টাইম কনস্ট্রেন্টে এটা জাস্ট গ্লকোমা সার্জারি রেভলিউশন নিয়ে একটা প্রেজেন্টেশন. So, understanding of glaucoma treatments started in the BC, before Christ, and has come a long way. There are still ongoing research and advancements in technology, and it still continues to be one of the most researched diseases in ophthalmology, because even now new theories are unfolding. Research is showing us new etiologies of the disease and new factors playing an important pivotal role in the disease. So some types of glaucoma were described as early as 400 BC by Hippocrates and Shushruta of India, but they did not term it as glaucoma, but they were describing a condition where the pupils were bright, slightly green, and the eye was hard and it caused blindness. Hippocrates called this condition glycosis. Now, what they tried to call glycosis, there are theories, but it has boiled down to that they talked of a condition when the eye was slightly greenish colored or bluish colored. But at that time the anatomy had still not unfolded, so they were attributing it that the eye was filled by some fluid, and there were changes taking place in the eye which was leading to this color. They tried herbal mixes and compresses at that time. It has been seen that thyme, which is a herb, was quite effective in lowering the eye pressure. So this was what to them was glycosis, and here there was loss of vision in these patients, and there was this light blue, gray or greenish colored eyeball, probably angle closure, but it is all probably because it has not been documented at that time that what they thought it was a fluid. Then later on it was thought to be the lens, and later on it was gradually unfolded that glaucoma has a different pathology. So the pathophysiology is multifaceted. It has now been seen that the elevated IOP, and even after so many years, hundreds of years of research and studies, we have only been able to control the IOP, which still continues to remain the most modifiable risk factor. And we know that when everything fails medically and with lasers, then we have to think of surgical intervention. So the first attempts of surgical interventions, which has been documented, dates back to around 1830, 1835, where they tried paracentesis and scleral punctures. But the first successful surgical procedure was by von Grafe in 1857, where he first he tried a sclerotomy, but later on he tried the iridectomy. And reading about him while making this presentation, I'm just fascinated by what a multifaceted person von Grafe was, and he continues to be the founder of modern ophthalmology. He is highly respected in Germany, where they have made this Grafe point, where there is a bronze statue, and with this writing there, and he is also the father of the German Ophthalmology Society. He is told to be the conscience of ophthalmology in Germany. He was extremely skilled, and he wrote this archives, which was in a span of around 15 years. He wrote 2,500 pages of this archive, where he has talked of everything: excavation of the optic disc, iridectomy, central artery occlusion, brain diseases, swelling of the optic nerves, choroidal changes, and tuberculosis. And he was famous internationally. He had lots of fellows, and apart from being a brilliant ophthalmologist, he also was a very good human being. He would treat a lot of patients free. He lived only 42 years, died of tuberculosis, and even when he was diagnosed with tuberculosis, he knew it was life-threatening, he would die, he still continued to practice. To him, this is what an eye meant. He says, so much for the organ which exerts an influence for the nourishment of our mind, for the foundation of our worldview, and for the relation of men amongst themselves, about whose extent the person in undiminished possession can barely give full account. Speakers have praised it, poets have sung it, but the full value of it, that is the eye, is sunk into the mute longings of those who once possessed and lost it. He was, at the same time, there was another ingenious ophthalmologist, Louis de Wecker. We have used his scissors, and it still continues to be one of our important instruments after so many years. And he was the one who brought in anterior sclerotomy. He tried to form a cicatrix in the angle of the eye, and through this the fluid would drain out, and there would be IOP lowering. In 1876, he also tried using a gold wire to drain fluid outside the sclera, and this was the beginning of attempting cetons, which many others tried, but none of them gave very consistent results. So the search and the research continued by Robertson, by Herbert, and we know of Lagrange, who did a partial sclerotomy and iridectomy combined together, followed by cyclodialysis in 1906, which can in a way be said to be the first suprachoroidal surgery. Iridonclysis by Holt, here the iris pillars were pulled out, and then they were snipped in between, and the iris pillars were acting like wick. They were left below the conjunctiva. But all these surgeries had hypotony. Sometimes the eye became phthysical. They were not calibrated. There was high risk of infections. Trifine by Elliott, goniotomy was one of the first angle surgeries done by which was done by Barkan as early as 1938. And this was the trifine holder and the trifine needles that were used for trifining. A punch was done at the limbus covered by the conjunctiva. Goniotomy, here Barkan used a modified Barkan goniotomy lens, and he used to just split a section of the trabecular meshwork. With the advent, and not the advent, it came earlier, but with advancements of surgical microscope, surgery of the trabecular meshwork people started trying to do that with trabeculotomy, sinusotomy, and trabeculotomy again by Harms in 1966, and we still use his instruments in trab and trab when we are operating congenital glaucomas. So in a way, the first 20 years of surgical innovation in glaucoma from around 1856 has still provided the basis for what we are doing now: trabeculectomy, tube shunts, procedures at the angle, and we have just been building up on those. So this was a surgery which was a landmark surgery by John Edward Cairns in 1968, and it still continues to be the gold standard, and it's been augmented by antifibrotic agents. Most popularly used is mitomycin C, and this still continues to be the gold standard. So the therapy in glaucoma is meant to maintain the visual acuity, the visual field, and reduce interference of the disease in the daily life. That is, maintaining quality of life, including trying to decrease the number of eye drops and its potential and ocular and systemic side effects. So large number of new glaucoma devices have been tried, and to improve the quality of life, to gift more sight years, but none of them has actually met met our expectations to deliver the goal to be calibrated with a reasonable risk profile. So the work then continued into the trabeculocanalicular outflow by doing non-penetrating deep sclerectomy, viscocanalostomy, canaloplasty, but they did not gain any widespread acceptance. Tube shunt. This was pioneered by Dr. Anthony Molteno, and these have now evolved a long way. We have a number of them in our platter, and they have a well-established role in glaucoma treatment, but they are confined to treating a specific class of glaucoma patients. So in 1969, Dr. Molteno first designed a tube to overcome bleb resistance and improvements, and then Barvelt. Then Amit glaucoma valve was introduced in 1993. What was before was a shunt. This was a valve. And then Express stainless steel translimbal implant, we tried our hands on it. It was introduced in 2004. It works well, but unfortunately because of the price, I don't think it is now marketed in India anymore. Our very own Adi continues to be a very valuable tool in treating patients at very reasonable costs. And now latest 2019, the Amit Clear Path, which is a non-valve device by Dr. Ahmed, designed by Dr. Ahmed. And the new kid on the block, the most dynamically researched subject now, is minimally invasive glaucoma surgeries, which is the latest on our platter of glaucoma surgeries. It encompasses a variety of procedures which are generally performed through very small incisions, causing minimal trauma to target tissues and have a favorable safety profile. Started with the trabectome in 2004, ICE in 2012. I'm talking of the ones that are more commonly used now. Kahug dual blade or KDB in 2015, Zen gel stent 2016, and 2018 Hydrus iStent inject. There are more than a number of other MIGs, but as I told you, this is what is commonly used in India. So they either work by bypassing the trabecular meshwork or enhancing the uveoscleral outflow. To enhance the uveoscleral outflow, the CIPUS was designed, but it caused corneal decompensation, so it has been withdrawn. Subconjunctival filtration, Zen gel stent and pressure flow, trabecular meshwork, ablation, Kahug dual blade, and trabectome. The efficacy of majority of these MIGS procedure in lowering IOP is lower than our gold standard trabeculectomy. This compromise in efficacy is compensated by a higher safety profile, as the traditional surgeries are also associated with potential sight-threatening complications. A broad range of intraoperative and postoperative complications are also associated with MIGS, but now through the years it has been seen that most of them are transient and resolve with time and with medical management, and it is becoming clearer to us with more and more RCTs and data collection as to which patient is suitable for which MIGS. But limited evidence is still available on the cost effectiveness of MIGS, whether the cost of the device will outweigh the cost savings from decreased medication, and whether the cost of further interventions or management of complications will also outweigh the cost savings from other decreased medication. So as of now, glaucoma surgery, which has evolved through hundreds of years, stands at some conjunctiva involving and some conjunctival sparing, some ab externa and some ab interna procedures, about which I have already talked. Thank you.
Thank you, Dr. Suchanda sir, for nicely covering this topic. I am in ophthalmology since early 70s, and I have performed and seen many of these surgeries in the early surgeries, like Elliott's sclerocorneal trephine that you have mentioned. I have performed myself, And it is interesting that Professor Elliott was professor of ophthalmology in Madras, if I'm not very wrong. Another surgery was at that time very common, that is seize operation. And few other surgeries like for aphakic glaucoma, we used to perform cyclodialysis. That was very common at that time for aphakic glaucoma. And the one that I have not performed was iridodialysis for acute glaucoma. The idea was to tear the iris from the root so that the angle opens up. But most of the time, it was not successful because the iris used to tear from the false angle, not from the false insertion, not from the insertion itself, from the ciliary
Sir,
body.
how did you do the cyclodialysis? Cyclodialysis কিভাবে করতেন?
Yeah, cyclodialysis we used to for aphakic glaucoma only.
কিভাবে করতেন? মানে
কিভাবে?
কোথায়?
Yeah. See, there is a cyclodialysis spatula. So you have to make an incision at this sclera about 4 millimeter or 5 millimeter behind the limbus. Make an incision, come up to the ciliary, ciliary level, ciliary body level, means, and then pass that cyclodialysis spatula and see that it comes to the anterior chamber.
Achha.
And then open it up.
So there was no
So,
bleeding? There must have been
Yeah, there could be some bleeding at times.
Achha.
But then the idea was so that the aqueous gets drained through that ciliary space. So those are the few surgeries that I have performed myself and I have seen. I'm so lucky to see that the present, it has developed so much, and I have been performing some of them today. Thank you.
I think what Yasir has said is what I have also done. Some of these surgeries, I remember that when we didn't have lasers in Calcutta, we used to do regularly peripheral iridectomy, if I'm not wrong, at that time, for acute angle closure glaucoma. And for absolute glaucoma, we had nothing else to do except try and do cyclocryotherapy all around 360 degrees so that the iris, the ciliary body doesn't secrete aqueous. And as far as the most common surgery which I used to do for open angle glaucoma was Shee's operation, which he did. But I have seen in Calcutta, when I came, the most popular surgery for angle closure glaucoma used to be iridectomy. You take out a slip of iris and put it under, it acts as a wig through which the aqueous would flow out. That was the most common surgery at that time, if I'm not wrong, in RIO and other places. Trabeculectomy had not come at that time. I remember I had started doing trabeculectomy right when I was in UK, and I started doing rectangular flaps and then to triangular flaps. This I learned over attending AIOS meetings where Dr. Ellen Sood propagated the triangular flap instead of rectangular flap, if I'm not wrong, because of the less number of sutures which arrived. And then later on, it developed with releasable sutures also. So these were the procedures which developed. And now you have so many shunt surgeries and all that for absolute glaucomas, which is quite an advancement. And even goniotomy and trabeculogoniotomy for congenital glaucomas. So that is the development, I think. You've done cover up very well. Thank you.
Again, my leg puller, Dr. Abhijit Ghosh. Anyway, ট্রাবেকুলেক্টমি আমাদের গ্লকোমা সার্জারি যেগুলো আমি দেখেছি আমাদের স্টুডেন্ট অবস্থা হাউসটাপশিপ বা পিজিটি বা ইউকেতে গিয়ে আমার এনআরএসে দেখা হচ্ছে ট্রিফাইনিং বাই ডক্টর সিআর খাড়া অ্যান্ড ট্রাবেকুলেক্টমি বাই প্রফেসর শীল. হিজ ট্রাবেকুলাম ওয়াজ দ্য মেটিকুলাস। এবং আমি যখন মালদায় ফেরত গেলাম, পিনাকি রঞ্জন রায়, আপনার নাম শুনেছেন, লেজেন্ডারি, হি ইউজ টু ডু সিজ অপারেশন অ্যান্ড আরেনক্লেসিস। অ্যান্ড ওখানে ওনার এক ভাইপো ছিল গৌতম দা, ডক্টর গৌতম রায়, উনি ট্র্যাপ করতেন। তো উনি মারা যাওয়ার পর আমাকে উনি পিনাকিবাবু জিজ্ঞেস করলেন, তুমি কি ট্র্যাপ করতে পারো? আমি বললাম, স্যার হ্যাঁ আমি করতে পারি। আমাকে গোলকশীল স্যার আমাকে নিজে হাতে ধরে ট্র্যাপ শিখিয়েছেন। তো ওনার হয়ে আমি ট্র্যাবেকুলামি করতাম। তারপর থেকে উনি আর সিস কিংবা আরেনক্লেসিস করতেন না। আমার এভলিউশন হচ্ছে এই পর্যন্তই। তবে আমার মনে হয় ট্রাবেকুলেক্টমি ইজ স্টেইং ইন গ্লকোমা সার্জারি ফর এ pretty long time. Now the MIGs are coming, trying to replace because of some demerits of trabeculectomy, because it is making the eye vulnerable for the rest of the life. সেই জন্যই বোধহয় শান্ট আসছে। আদারওয়াইজ trabeculectomy is the surgery for glaucoma, still holding good still now, unless MIGs becomes successful, cheaper, and of course I think it is easier to perform.
Yeah, it's true. Actually, there was not many medicines in those days. We had only pilocarpine, 2% and 4%, 1%, 2%, 4%, and we had epitrade and timolol. Timolol came when we were house staff. We saw timolol. But I was doing house staffship under Dr. G.N. Shil, as he said, and I saw him doing trabeculectomy, and I would say till now, that's the best way he used to do in those days. Because trabeculectomy, we did surgery without any microscope, only a loop. So dissecting the scleral, this bed was slightly difficult. That Shi's operation was much easier. Irenclesis was an easier surgery. And doing that because there was a chance of dissecting the sclera hole. And he used to do, I remember, when he used to do the scleral flap, removing the everting the scleral flap, he made 2 vertical incisions, and he used to put a thin wire that was 10 or something like that, thin wire like.
That is the stillet used to clean the needles.
Yes, exactly.
To find out the Slem's canal.
And he used.
Without microscope.
And he used to put it from this side to that side, and he used to do it this way. And his results, because I was the house staff, and I know his results were excellent. And because those were naive eyes, without giving any medicines, because when we did surgery in 80s, late 80s and early 90s, the trap patients which we see now has such a beautiful bleb, but surgery which we have done in 2015, 2016, they are not so good, because they were naive patients, and the results were much, much better.
Professor Shil was trying to do nowadays, which is called trabeculotomy.
Yes.
The sweeping, that one. He did it in front of me. In lack of that particular instrument, he couldn't do it. He tried to circumvent the total trabecular meshwork with the wire and tried to pull it out. But I understand now, he had a microscope at that time. You'd have been successful, and a nice paper would have been out. Long back, 82, 83.
Thank you so much for that invigorating discussion and very detailed glaucoma history. Coming to the next topic, which is evolution of the retina surgery by Dr. D.N. Chattopadhyay.
Good morning, everybody. My friends, seniors, juniors. I'll be trying to say something about the evolution of retinal surgery now and then. Now I am not going to say anything, because we know that now it has improved to a great extent throughout for the last 10 to 15 years. But I will give you some tips about when it was in early 80s or late 80s, like that. Now, retina surgery was little late to develop all over the world. For some example, even the discovery of direct ophthalmoscope was not taken up very seriously by the then ophthalmic giants in the Western world. They were of the opinion that only those who has their brain not working that much, they require an extra light to see the inside of the eye. FFA, the first presentation was refused for publication. Anything behind the lens was practically beyond something cannot be done. Nothing can be done. And Crookes colossal iodine-like drops were the only medicine used in these type of cases. But science didn't stop. There were many steps like the oruga stings, diathermy, etc. And ultimately, we have reached this stage. The most important thing was the discovery of indirect ophthalmoscopy by Charles Kiffins. And that helped us in identification of the exact break and treatment accordingly. Now, many of us here, like Dr. Devashish Bhattacharya, Dr. Arup Chakraborty, and few are also not with us nowadays, we attended the Asia Pacific Conference in New Delhi in 1985. That actually gave us a little bit inspiring things, that something can be done. We saw the Pruitt working in front of us, Akira Momose of Japan working in front of us. So we were much enthused to see that thing. And the next year, in 1986, 86 AIOS conference at Kanpur, Professor D.B. Chandra was the president, and in his presidential address, he said, those who are not using indirect ophthalmoscope and operating microscope routinely, you do not know what you are missing. What a foresight was there. Even today, I am afraid we are not using indirect ophthalmoscope routinely. But in 1986, Dr. D.B. Chandra could foresee this thing. In 1984, when I joined RIO, there was a special section called RRC, where Dr. D.P. Ganguly, our very respected Dr. Pronam Chatterjee, they were working. They suddenly left RIO to other centers, other medical colleges. And when I joined there, I was working with Professor P.N. Biswa. Thank you, Pradut. Then our very famous, I don't know whether I should call him famous or notorious, Dr. Abhijit Ghosh joined us. And after that, Dr. Devashish Bhattacharya, Dr. Arup Chakraborty, etc., they joined us. And we had a group there in that RRC room who were doing something, were trying to do something about the retinal detachment surgery. The usual concept at that time was routine 360-degree encerclage with 3 mm silicone sponge with 360-degree cryo. But we tried to change that concept. We tried to localize the breaks and to seal the breaks. And the most practically, the revolution started with 360, with tires and 240 bands. So with that thing we started. These are some memories of our RIO days. Do you have, I saw the Durgada here. Yeah. Bolun?
The splitting of the sclera and with scleral buckling and 360-degree encircled band at that time. And naturally subretinal fluid with subretinal fluid training.
Yes. Thank you, Anitati. But it was surprising that even with those very crude maneuvers, what my observation, and maybe my that time comrades will all agree, that about 75% of the cases ended up with flat central retina. Gradually the concept came that the vitreous is the main culprit in retinal detachment, but we were penalizing the sclera unnecessarily. So we adopted the advanced techniques like 360-degree encirclage and cryotherapy with sponges imported from Dixie Company of London. We started treating intraocular infections with intravitreal antibiotics like gentamicin with decadron with excellent cure for the infection. But somehow the incidence of disc damage was much more in those cases. Later on, vancomycin, amikacin, etc. came with very good results. During those days, when phacoemulsification was coming, most of the anterior segment surgeons they were also practicing phacoemulsification, resulting in lots of nuclear drops and intraocular postoperative endophthalmitis also. Around 1987, Appasamy Associates came up with a single port VISC, VISC. I think Babulullah and others will remember those things. Those were not of real help in the long run. Then came the idea of irrigating assistant-held contact lenses, which were of very much help. Soon after came the era of biome and 20-gauge cutter, which changed the outcome of vitreous surgery for quite a long time. Nowadays, even our RIO is having the Alcon Ingenuity 3D vision system, which is being used by the surgeons with very good success. These are some memories, those irrigating contact lenses, biome, and to the ingenuity of today. Now, it was eventually understood that in cases of advanced PVR or different membranes, only buckle is not going to work, and things change to 23 gauge, 25 gauge, 20 and even 27 gauge, and with high-speed cutting rates. With time, vitrectomy cutters with high speed and the performance improved a lot. Nowadays, with advanced instruments and better techniques, most of our retinal diseases can be treated with confidence and certainty. These are few pictures of the different types of cutters, etc. Now, another thing we observed that time, the diabetic retinopathy cases were being treated with initially laser xenon arc and then the argon or other laser type of photocoagulation. But it was not understood why even the well lasered cases also did not improve in vision. Gradually, the concept of VEGF and the treatment with intravitreal injection of anti-VEGF injection came into play with much better outcome. These are some few memories of those days. We can see Dr. Kajal Ghosh, Dr. Abhijit Ghosh. We had some even outstation camps. This is one such in Darjeeling. Thank you very much.
Good evening. Actually, our era in retina started with this man. He was more of a friend, philosopher and guide. So, but previously, I would add to Devuda, in 1970s, Calcutta has seen retinal detachment surgery using the modern system of indirect ophthalmoscope by Dr. Somir Biswas. Because he was the one, Osimda will say, he's not there. He was the one who, Osimda, am I right? Huh? Yes, cryo probes were being created by you people, is it? He brought it from Boston also. I thought I should add this because it was there.
See, I was there when Dr. Somir Biswas came from UK. I was in, at that time it used to be called Eye Infirmary, not RIO. So he started doing retina surgery with indirect ophthalmoscope. He first introduced indirect ophthalmoscope in Kolkata. Later, his interest shifted to cornea. He went to Boston, came back and started eye infirmary. But the father of retina surgery, as I have been told in Kolkata, was Captain Kiran Sen. Yes. And later, I found Dr. Murali Sengupta, Dr. Balai Mitro, and Dr. Parag Mondal performing retina surgery. The surgery at that time was just scleral buckling with drainage of subretinal fluid and diathermy. And the patient used to lie with both eyes bandaged for sometimes months together. So that was my experience in Kolkata with retina surgery.
So Osimda, they knew they used to prepare cryo.
Only thing that time inbuilt cryo was not available. So Dr. Somir Biswas has got different type of molds. And Joduda, Dr. J.N. Mitro, he was the senior BMS house surgeon, I was the junior house surgeon. And whenever there is a retinal surgery, patient party used to bring one carbon dioxide cylinder. And the dry ice was formed, and by pressing over the different shape of the mold, sometimes it is sharp, sometimes it is rounded, those molds were sterilized and lying on the trolley. So we used to take the ice and press it over the different shape of the mold, then it became a sharp or round one. And another thing is that SAD used to do surgery with the indirect ophthalmoscope, and we used to clean the lens with a sharp flake. Sharp flake. After that, sterile water is poured over the lens, and it was ready for the surgery. And second thing is that, what Anita Di told, SAD used to do scleral dissection, resection, put diathermy, and localize the area where he will give a extra plumb, then he have to give a round band. That is the theory. And what Devnath said, usually traumatic detachment or giant tear result were very, very good, except where the vitreous is disturbed, you know everything. Sir used to bring a vitreous cutter, scissor, but those days, because the tenure is very short, so he died at the age of 42, so that thing becomes static now. And he used to do all sorts of surgery, including the keratoplasty, and he brought some IOL in 1973, and he was showing us that he will put this disc IOL. But destiny has other say. Thank you so much.
I will tell you a story regarding Professor Kiran Sen. Professor Kiran Sen operated on a very important patient. She was Ketuki Kushari Dyson. Ketuki Kushari Dyson had retinal detachment because of high myopia. And Ketuki told me on a private basis that he was the man he adored as the god, because in those days, about 60 years ago, she was operated by him by diathermy and lying down, and she is going strong, and she is very proud of it. So we all should be proud of those gentlemen who have done so much for us. And there is one person who we need to not to forget, it our Priyo Pranabda. P.K. Chatterjee, he was one of the very builders of one of the most important teachers of retina, modern retina, I would say. Thank you.
Actually, Dr. P.K. Chatterjee and D.P. Ganguly, they brought the recent trend in Kolkata. So, is there no other discussion? Thank you very much.
One thing I just want to add regarding Dr. Kiran Sen. He did a retinal detachment surgery in RIO when Dr. Pattonayak had retinal detachment. Dr. Pattonayak was operated in RIO, that time eye infirmary. And he stayed in the eye infirmary ward, lying straight for 1 month. And he was cured. Dr. Pattonayak himself told me in a conference that he was operated by that legendary person, Dr. Kiran Sen, and he is all right, and he is doing all the surgeries with those eyes. Thank you very much.
May I please invite Dr. Parag Mukhopadhyay for the next talk on evolution of cataract.
Pronam to my seniors and accepting pronam from my juniors. Pronam is the key word today, and I must place my pronam to OSWB. কারণ আজকে এই প্রোগ্রামটা ইমোশনাল করে দিচ্ছে কিছু মানুষকে দেখে। ডক্টর বি কে বড়াল শিখিয়েছিলেন ব্যারাকারটা নিডল হোল্ডারটা কীভাবে ধরতে হয়, কী স্টাইলে 80 নিডলটাকে হোল্ড করে স্টিচ দিতে হয়। যখন বেরিয়ে গেলাম আড়াইরো থেকে, কোথায় অপারেশন করব, প্রাইভেট অপারেশন হতো না সেই সময়, ক্যাটারাক্ট সার্জারি, শুধু ক্যাম্প হতো স্কুল বিল্ডিংগুলোতে ছুটিতে আর সরকারি হাসপাতালে। আমি বেরিয়ে গেছি, পাশেই বসে আছেন রমেনদা, ডক্টর আড়েল সাহা। বিভিন্ন ক্যাম্প হাওড়া জেলায়, তিনি একজন হাওড়া জেলার বেসিক মানুষ বলে কলকাতায় থাকলেও বিভিন্ন ক্যাম্পে নিয়ে যেতেন, হাতটা আমাদের তৈরি হতো। সার্ভিসে জয়েন করলাম প্র্যাকটিসিং পোস্টে বলে অল্প মাইনে। কি করি, সেখানেও একই অবস্থা, আউটডোরে সরকারি হাসপাতালে অপারেশন করছি প্রচুর, আর ক্যাম্প ওই জেলার যত আই ক্যাম্প করছি। হাউ টু আর্ন মানি বাই সার্জারি। একজন বুদ্ধি দিল আমার কলিগ, আসানসোলে একজন ডাক্তারবাবু আছে, উনি রুগীর বাড়িতে গিয়ে প্রেশার কুকারে ইনস্ট্রুমেন্ট স্টেরিলাইজ করে অপারেশন করেন। সমীর দা বসে আছেন, ডক্টর সমীর রায়, আসানসোলে। প্রণাম OSWBকে, সবাই আজ হাজির। We know embryologically that crystalline lens develops from surface ectoderm, a skin and enamel of teeth. So it gets old, only the crystalline lens gets opaque, and gradually it is a hindrance for the visual axis and it needs removal. So from early primitive days, that removal procedures are continuing till date. You see, couching, it was the primitive procedure when the lens was pulled to the vitreous body and the visual axis became clear. This is von Graffy's cataract knife. Shuchandra has told so many things on von Graffy. He was really brilliant, and within 42 years of his life, he contributed so many things in ophthalmology. And this also, Dr. B.K. Baral taught me how to hold the von Graffy's knife, and we started our career with von Graffy's system. Isn't it not, Devashish? Taito? Dr. von Graffy. He secures position in 2 presentations. So how much great his contribution was in ophthalmology. Then one surgery. Yes, we told, আমরা অনেক গল্প করেছি তাই দেরি হচ্ছে. That intracapsular cataract surgery with a section of von Graffy's knife was the updated surgery in our time when we started ophthalmology. It is practiced in Moorfield, it was practiced in RP Center, it was practiced in RIO, and everywhere I practiced it in a camp with Professor I.S. Roy. See, that time we thought that gloves, powders will be introduced inside the eye and make the sepsis, bare hand. And dress in the camp Genji, that is the very most sterilized, no apron, no gloves. See, intracapsular cataract surgery, I am holding the lens, performing the camps in hospitals and outside. This boy, that was pediatric surgery, was not that time. Pediatric ophthalmology was not a branch. So under G, I performed the surgery on the boy of 3 or 4 years. And after 40 years, he came, met me and told me, Dr. Babu, আপনার জন্যই আমি পোলট্রির ব্যবসাটা করে খাচ্ছি, ছোটবেলায় কিছুই দেখতে পেতাম না. So he is taking the plus 10 spectacle and passed his whole life. Then came the microscope. This is a very basic microscope of Appasamy, and I used to go to rural hospitals and perform eyewear surgery in camps, me, with my patients, with my assistants. Then came the concept of IOL, canopnar capsulotomy, first when there was NICS, not CCC. After that, for the seniors who left ophthalmology for many years, if anybody is there, I think my teachers are there, few teachers. Ramenda Vijayada is not performing now. Now it's a concept that complete curvilinear capsulorhexis, CCC. It is the best invention, I think, in ophthalmology, by which we can very confidently perform surgery without any fear, and we can do anything, convert anything for this procedure. Yesterday I did this surgery, so I just included it in my presentation. It will take a little time. It was a very matured cataract, grade 4-5. I planned for SICS, and I am taking a little time for this surgery. And this is the capsulorhexis, CCC. Next. Only the nucleus is dislodged in the anterior chamber. This way, If someone is not very active in surgery, for them only. It is taken in the antechamber. This is the Simcoe cannula. From one channel, water enters from the bottle in the height, and by the another, the cortical matter is washed out. And rigid lens I am introducing in this case this way. Okay, dialing and positioning the lens. And in phacoemulsification, the lens is being eaten by the phacoprobe. That is the difference only. And the foldable lens is being introduced. I do not perform this surgery. I only take it from others. This is the new femtolaser cataract surgery. Sometimes the pupil is very much constricted, particularly those people who take for their benign hypertrophy of prostate, tamsulosin. In that situation, difficulty in surgery happens because cataract surgery basically needs a dilated pupil. Our very own Dr. Suhen Bhattacharya invented this one, a pupil dilator. So the small pupil becomes hexagonal with the introduction of this device. To get introduced to the modern surgery, you need to meet many friends to discuss many things. I had to undergo many programs, attending these programs and academic programs too. All my friends are around me. I take advices from them, I learn from them. I learn through these programs also, phaco training program by Alcon. Now, I am waiting for the day when my young brothers, you stay healthy, unlike our Ajaypal, you stay healthy, you live long. I am selfish. Someday, I want that I do not need any spectacle. I can see distance, middle vision, near vision with the new IOLs, with the new device, and with magic touch of your hand, so that I can get back my vision as I had this parag. Thank you.
Quick comments, please.
Thanks to Dr. Parag Mukhopadhyay for beautifully covering the subject. I have a little addition. Before this present day ECC, in the beginning there was another technique, extracapsular cataract extraction. I do not know if you are aware of it. That was the earliest surgery before intracapsular cataract extraction. Both were going side by side. In that, we had an instrument called cystitome with lens curette. And the cystitome, like not the needle one, it's a cystitome with bent end. And after making the section, we used to make a cruciate incision in the anterior capsule, just cruciate incision, making the anterior capsule having 4 flaps. And then with the lens curette, by pressure and counter pressure, we used to take out the nucleus. Sometimes, some people used to wash the anterior chamber with saline in the syringe, sometimes just leave it like that. And that was the reason for which cataract used to be performed only when the cataract was mature, so that you do not leave behind much cortical matter. That was the earliest operation. Those cases which are mature, where holding the capsule with Elsnick's forceps or Oroga's forceps was difficult. In those cases, this was the surgery that used to be performed. At that time, there was no suture. We used to leave a conjunctival flap. And later, suture was started with, by threading the needle, these silk sutures. When again Dr. Somik Biswas came from UK, he brought this virgin silk. That was also used to be threaded, not atraumatic. And interesting is, in eye infirmary, in the beginning I found people going to the OT with shoes. This probably do not know, many of you, because you are not at that time probably in RIO, I was there. First 5-6 months, I found people going to the OT with shoes. And we had a nail cutter in the surgeon's room. Before going to the OT, we had to cut the nails, because the surgery used to be performed barehanded. But the technique was mostly no-touch technique, so that the part of the instrument that you insert inside the eye, you do not touch with your fingers. And at the end of the cataract removal, we used to put air in the antechamber. And to make the air sterile, the air used to be drawn from a flame. There was a burning flame, and you draw air from that, let it get cooled a little bit, few seconds, and then put it in the antechamber. That's what we used to see at that time. And in Kolkata at that time, only Von Graff's knife was there that was being used. First time I found people using scissors was at RP Center. There I found nobody was using knife. No, few people were using. Professor Sood was using knife. Most of the people were using scissors. And when I told this to Professor Parag Mondal, he said, see, knife is a cutting instrument and scissors is a crushing instrument. So if you make the section with scissors, you crush the tissue. That is why we do not use scissors. That was his explanation.
I'm not talking about what is the perspective of all India. If in West Bengal, there is one game changer in eye surgery, and that is that man, Pudipda. Please give him a big hand. He is the person who has changed the complexion, Pudipda. We are all indebted to you. He has changed, and Dr. Pawa. These are the persons who have been the game changer. I hope you all agree. And this is my tribute to Pudipda for all you have done for us. Thank you.
Well, thank you everybody for that, but I really don't deserve it, because before me, there were few other people who were doing IOL surgery. I can name few of them, but I think Pawa and myself, we made it popular. And that's a different story. I don't want to blame the old soul there. Yeah. The thing is, at that time, nobody would show their surgery to anybody. But when I got disheartened by that comment which Babulal made, that someone who was doing surgery would not let me come and see his surgery because I would take away his patients and he would be without any patients. That's why he didn't allow me. At that point, I made it my firm promise that any and everybody, be it my most, what I would say, most enemy, I will still, if he wants to see my surgery, I will call them. And the other thing which I used to do is like Kajol and others, I used to say, "Arey, tor patient আমার কাছে আসছে, তুই কেন start করছিস না? Why don't you start it?" So that's how I made it a bit more popular. And that's the only thing which I did, nothing else. Thank you. I was present at the time when it was there.
Now I would invite Dr. Kushal Chaudhary for his talk on evolution in cornea surgeries.
Right at the outset, I must thank Rupok for having chosen me for this particular talk. I must confess I had absolutely no idea what a great morning this is going to be. I took it as just another day, just another talk. I have to do a little bit of search, literature search, prepare my slides, and come here. But I guess today is a day when the speakers, at least our generation speakers, we are telling less and learning more. And whatever is being shown here on the screen, I think is just a basic something with which to start the conversation. And what a conversation we are having. Thank you so much, seniors and teachers. This is an unforgettable experience for me. Today, I will be talking on evolution in ophthalmology. Now, every evolution in ophthalmology, any one particular thing, you can keep on talking about it for days on end and yet not complete everything. So my attempt here is going to be very, very sketchy. I'll just go through the various things. Given my age, I don't have too much experience to talk about. I will be very keen to hear from my seniors about their experiences in this particular field. I am sure we will have a very, very interesting discussion. So, like I said, there are so many things which have happened in the development of corneal understanding and management. I will just name only a few. Pardon me if I am not naming all of them because of lack of time. Now, there's something that cornea, the most important thing about cornea is that it's a transparent organelle. And David Morris, with his lattice theory, tried to explain this, first of all. The fact that cornea has nerves, it was first found out by the extremely talented scientist, Friedrich Schlemm, who is more famous for his Schlemm's canal. And more recently, Richard Thoft, who propounded the XYZ theory of corneal epithelial wound healing, also started the first keratolimbal autograft. Now, these are not so familiar to us because we are not dealing with it every day, but the diagnostics of cornea, these various instruments, they allowed us to understand the tissue and thereby improve our therapeutics. The slit lamp was developed independently by Gullstrand and Helmholtz. Now, most important, interesting thing that I found is the design of the slit lamp by Gullstrand. He took it to Zeiss, and Zeiss took that design and developed it further, and Helmholtz took his design to Haag Street. So we have two different line of slit lamps till now. One is the Zeiss type and other is the Haag Street type. Now coming to corneal curvature. First of all, scientist Placido, he he discovered that he can use these multiple alternating rings of black and white rings, and the Placido's disc was one of the most important developments to develop the corneal curvature. We are still using this principle in modern corneal topographers. Helmholtz made the first fixed position keratometer, and after a few years, Zawal was the teacher and Schiotz was his student. They together developed their own keratometers, and based on these keratometric principles and Placido disc principles, Stephen Kleiss in 1984 at Louisiana State University took the whole data, computerized it, and thereby the first topographers were made. I'm sorry I don't have much pictures. The slides might be a bit boring. It's because last night my laptop crashed. Along with that, everything went away. So this is just a very sketchy presentation that I'm making. Pardon me if it's not very interesting. Now, topography was based on the Placido discs, which Placido found. And the tomography, there are two types, the scanning slit and the Scheimflug types. Scanning slit was made by the company the trade name was OBSCAN, which is now obsolete for various reasons. The Scheimpflug type, which is the Pentacam, is currently reigning in this field. OCT is also used, and I think we'll see more of this OCT technology develop in the finding out the corneal curvatures. Pachymetry has been of various types. The first pachymeter was a slit lamp based optical system where two glass plates were placed close to each other, and by a knob, this was a slit lamp base, and by a knob they used to change the angle between the two glass plates, and by the amount of angulation that we achieved to coincide the anterior optical slit surface and the posterior curvature, we used to find out how thick the cornea was. But ultrasonic technology developed further, and we have ultrasonic pachymeter in two types. One is we can do it with a single probe, the small probe which we are all familiar with, and ultrasonic biomicroscopy also can be used with its higher frequency and very nice pictures. Now, specular microscopy can give us pachymeter, anti-segment OCT, optical biometry, as well as corneal tomography, the Pentacam. Specular microscopy was again developed, the principles of it by David Morris, whose name we took earlier. Confocal microscopy is an instrument by which we can see each layer. Epithelium, we can see the epithelium separately, we can see every, progressively deeper and deeper into the stroma, and we can see the corneal nerves, we can see the keratocytes, we can see the pathogens, like fungal filaments and everything. Corneal hysteresis is a machine which tells us about the corneal biomechanical properties. We can see we can calculate the corneal aberrations. There is aberrometers with a topographer. So we take the whole ocular aberration and we subtract the aberrations out of that using the corneal data from the topographer. Corneal ulcer management. Long back, we were using things like scraping and trichloroacetic acid cautery. For antibiotics, we had chloramphenicol, gentamicin, sulfa tetracyclines, and ciprofloxacin was the real game changer, which came in late 80s. It was the first fluoroquinolone, and since then, only thing that has developed is we are getting more, next generation fluoroquinolones. Natamycin as the antifungal came in the late 80s. That time, miconazole was also developed, came as mycoptic ointment, but it was withdrawn because of lack of efficacy and a lot of irritation. Antivirals, idoxuridine was the first antiviral developed found in 1962 for human use by Herbert Kaufman. It came in India in 1969. Acyclovir came in India in 1987. Excimer laser revolutionized refractive surgery. Dr. Mani Bhaumik, our very own Dr. Mani Bhaumik in USA, was instrumental in developing the physics of it from late 60s to early 70s. It was used mainly for industrial uses. But later, around 1980, Dr. R. Srinivasan and his team, they found out how precise the laser can be in making marks on the human hair. And thereby, they thought that it can be used for precise eye surgery. Femto has come and it is getting supplanting a lot of things which were done by the blades. Coming to corneal graft, again, the history is very, very old. Edward Zim was the first person who performed the first successful corneal graft. Momeni and Khoda Dost, they found out the basic principles and the signs and symptoms of corneal rejection and what to do with them, how to treat them. There were many, many people who developed micro-instruments, sutures, and brought about a lot of refinement in corneal graft surgery. And eye banking Association of America was started in 1960s. They used to, in those days, they used to take whole eyes. We used to do that in India also. And Macquarie Kaufman, again by Herbert Kaufman and his colleague Macquarie, they developed this MK medium, which allowed to keep the cornea healthy for transplantation for up to 4 days. So that was a good revolution. In India, the first corneal transplant has been recorded in 1948 in Chennai. At RIO Chennai, the eye bank was started in 1945. Then various individuals in various corners of India, they developed the eye banking and the corneal grafting. At RP Center, it was developed in 1966, established Shankar Netralaya 79. In Indore, Dr. Vasundhara Kalivar and Dr. RP Zanda did a lot of corneal work. And our very own Dr. Samir Biswa, about whom so much has been said with very good reasons. He was active in late 60s to early 70s. And I have heard anecdotal stories about the extremely good quality of his grafts. He was a real pioneer, and my pranams to him along with all those seniors present today here. Eye Bank Association of India was started in 1989. It has been doing yeoman service, and we are very happy today that the corneal grafting revolution has really spread to every nook of India. And in Kolkata, our eye hospitals, our very own eye hospitals, Disha, Sushrut and RIOs, they have been doing excellent, excellent work in developing this. And today, there are so many corneal surgeons doing fantastic work. Corneal refractive surgeries also have got a long history of evolution. Started with keratomileusis by Dr. Baraker. They used to take the cornea, freeze them, make it really solid, then reshape it using a cryolathe, and then put it on the patient's cornea. It was either patient's own cornea which they took and reshaped, or it was an allograft. But this didn't really take off because of the various technical difficulties. Radial keratotomy was started by Sato, a Japanese surgeon. He was initially doing these cuts on the endothelium with not very good results. Later, it was changed to cuts on the anterior surface. And there were a lot of problems with the radial keratotomy mainly because of the hyper enthusiasm which people had. The surgeons often did more than what the eye could take. And then excimer laser came back into this refractive surgery area. And PRK was the first excimer laser refractive surgery. Later on, it was supplanted by LASIK and its variants. Femtolaser has come in a big way, and femtolasic and SMILE are the current very important cornea-based refractive surgeries which are being performed. In the future, I think we will be seeing more of work on artificial cornea, stem cell research, endothelial cellular culture and transplant, scar modulation, where there will be techniques to reduce the scar and improve the outcome of any corneal ulcer and stuff like that. And who knows what else is in store for us. Thank you very much, OSWB, once again, for my humble attempt at merely enumerating some of the things which I think have really changed the way corneal management is being performed. This is a very, very great day for me. I'll remember this day forever. Now, I will request the seniors to tell us about their experience in this field.
I had the privilege of seeing wonderful, about 8 or 10 years back, few of my patients who were earlier operated. I remember one patient who came and he was, very proud to say that my keratoplasty has been done in one eye. And I just looked at him and his vision was practically normal. I don't remember, but it was maybe 6/9, 6/12 or so. I looked with a torch and I didn't see anything. I didn't find anything. Then I looked at the slit lamp and I saw it was keratoplasty was done, but no suture marks were seen. And earlier I used to have seen quite a good number of patients being done at the premier institutions of the country, and I could see the suture marks there. So then I asked who said it, and he said proudly it was done by Dr. Somir Biswas. And I talked to Ashimda because I know Dr. Ashimde was, he was assisting Dr. Biswas. And he told me that he used to do with the hair from, take out the, it's wonderful to see with what instrument he used that the suture marks were not visible. It was amazing, amazing. Trefined, yeah.
যে রাফনেসের একটা দাগ হয় সেটা পর্যন্ত থাকতো না
Exactly.
জাস্ট একটা থিন
And not much of cylinder also. That's the beauty.
Sir used to center the cornea with an instrument that is called Amslad corneal marker with a 4-prong thing. And those days this inbuilt pencil is not available. Jensen Violet was trained over those 4-prong needle, and he put on the just center of the cornea, and we have to see that side. Yes, you see it in the center. One side me, other side Joduda, because whether it is in center or not, that is the most important thing. And another thing sir used to do while cutting the cornea, there must be very sharp cut. There should not be any ledging. So there's vertical cut. And every time he used to stitch, there must be formation of diamond. And if there is not formation of the diamond, after putting 4 stitch, he used to loosen the stitch and again he re-stitch it. That is the reason.
That's the beauty. That's the beauty.
Here I have not seen. I have seen this virgin silk reel, and sister used to thread it over the Gessever needle with a knot.
I have seen him suturing the corneal stitches with hairs, ladies' hair, long hair, Gessever needle. And that used to be so thin, that less than 10 sutures. But see, he used to that hairs also.
Sir, in those days, how were the eyes retrieved from people's homes or from the hospital?
Actually, I don't mind if I say it is stealing. Stealing. Simply stealing, though it is not permitted to say it, because counseling is very difficult. Everybody will revolt. So with the house club group and our friends in different departments, so that time it was a rather, because sir actually he did 90 cases in 6 months. And what was the preaching is that as early as you can. So whenever you just enucleate the whole eye, inform sir, and sir used to come even in the dead hours in the night. So because there was no media, only normal saline in a 4-degree centigrade. And as soon as you can, you have to utilize that thing. Otherwise, the material will perish.
We will move on to our next session. I would invite Dr. Shugotopal to please come. Thank you, sir, for the enlightening discussion. Thank you, sir.
So, good morning, everyone. For the next session, I would like to call upon as chairperson Dr. Debnath Chattopadhyay sir on the stage, please. Dr. A.R. Banerjee sir, Dr. Ashit Ranjan Banerjee sir, and Dr. Gautam Bhaduri sir. Dr. Bhaduri is not here, so can I please call upon Dr. Pannal sir, please, sir? Sir, can you help kore dao keu? So the first talk will be given by our President, Dr. Devdash Mukhopadhyay. He will be talking about the ideal environment. Devdash, please.
না 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 আমি তোকে বলছি ঘটনাটা বলছি থ্যাংক ইউ ফর গিভিং মি দ্য ওপেনিং আমি এটা প্রিপেয়ার করতে গিয়ে লস্ট মাই সেলফ যখন আমি স্লাইড লাস্টের দিকে গিয়ে আর আরে অ্যাম্বিয়েন্সটা কী বলবো দ্যাট ইজ অ্যান অ্যাবসলিউট অ্যাবস্ট্রাক্ট থিং বাবুলালে লেক পুরিং বেঁচে এসছি তাহলে আমার তো অ্যাম্বিয়েন্সটা তোমাদের বুঝে নিতে হবে সত্যি বলছি এটা আমি ঘেঁটে গেছি My experience as student is profound, prolonged and till continuing. As a teacher, humble and negligible. So ambience to এইভাবেই আসবে as a student and as a teacher. And as I feel, what do the teachers do? Hey Babulal, hey, shun. No collateral please. আমরা মাস্টারমশাইরা কী করে ছাত্রকে কাঁধে তুলিয়ে দেখায় আমার খুব একটা মনে পড়ে যাচ্ছে পিসি সরকার জুনিয়র বলেছিলেন তার বাবার সম্বন্ধে অনেকে বলে পিসি সরকার জুনিয়র নাকি বেটার দেন পিসি সরকার সিনিয়র বলে এটা কিছুতেই হতে পারে না আমার বাবা যদি আমাকে কাঁধে তুলে না দেখাতো আমি তো পৃথিবী দেখতাম না আর সবাই মনে করে আমার হাইটটা বেশি কিন্তু আমি যে বাবার কাঁধে বসে আছি এটা কেউ দেখে না আমি মনে করি দ্যাট ইজ ট্রু আওয়ার টিচার্স আর কিপিং আস অন দেয়ার শোল্ডার অ্যাজ ইফ আমরা টিচারের থেকে বড় আমরা টিচারের থেকে বড় কোনো দিন হতে পারি না ইম্পসিবল কারণ আমাদের মধ্যে টিচাররাই বসে আছে আমরাই টিচারদেরকে দেখাচ্ছি উই আর জাস্ট কুরিয়ার্স টিচাররা কী করে মোস্ট অফ দেয়ার নাইটস প্ল্যানিং হোয়াট টু বি টট নেক্সট ডে এক্সপ্লেনিং হাউ দে উইল বি ডুইং ছাত্ররা কীভাবে করবে অ্যান্ড আফটারনুন কারেকশান তুমি এই ভুলগুলো করেছো এইগুলো এটা মাস্টারের ডিউটি অ্যান্ড ইয়ার্স এনকারেজিং অ্যান্ড লাইফ স্ট্রেসিং দেম ইম্পর্টেন্স অফ লার্নিং অ্যান্ড টিচিং অ্যান্ড অল ইজ ফর ইউর ফিউচার অফ দ্য স্টুডেন্টস এবার ঘাঁটতে শুরু করেছি আমি টিচার্স কি এক্সপেক্ট করে ইন রিটার্ন নাথিং ওয়ার্ল্ডলি মেটেরিয়াল নো ইউর রেসপেক্ট নো Your recognition, care a straw. Then what? Your success. That means student success. এটা আমি মাস্টারমশাইদের কাছ থেকে আমি যেটা ফিল করেছি ওনারা কি চান অ্যান্ড দিস স্টোরি ইজ ইটার্নাল আমার মাস্টারমশাই আমাকে শিখিয়েছে আমি যদি মাস্টারমশাই হয়ে থাকি আমি আমার ছাত্রকে শেখাবো সে যদি মাস্টারমশাই হয়ে যায় সে তার ছাত্রদেরকে শেখাবে দিস ইজ ইটার্নাল And teaching atmosphere that creates the ambience is an abstract feeling that does not have any metrics like air quality index. It entirely depends on how the student accept his or her teaching. Then I am lost. আমার আর বলার কিছু নেই অ্যাম্বিয়েন্স কি তুমি কি পাচ্ছ তুমি কীভাবে সেটাকে ইউটিলাইজ করছো এবং ইউটিলাইজেশনের ফিলিংসটা কি দিস ইজ দ্য অ্যাম্বিয়েন্স নাথিং মোর দ্যান দ্যাট একটা গরিব ঘরের ছেলে যা খাচ্ছে যা পড়ছে যাতে সে সন্তুষ্ট থাকলে তার কাছে সে অ্যাম্বিয়েন্স ইজ গ্রেট আবার আদানি আম্বানির কাছে চলে যাও দে মে নট বি স্যাটিসফাইড উইথ দ্য প্লেথোরা অফ দ্য ওয়েলথ দে হোয়াট দে হ্যাভ সো অ্যাম্বিয়েন্স ইজ নাথিং ইজ অ্যাবস্ট্রাক্ট ইউর ফিলিং হাউ ডু ইউ ফিল হোয়াট ইউ আর গেটিং ফ্রম ইউর টিচার অ্যান্ড হাউ ইউ আর রেসিপ্রোকেটিং ইউর টিচার্স টিচিং সো দ্যাট দ্য টিচার ইজ অলসো হ্যাপি উইথ ইউ দিস ইজ অ্যাম্বিয়েন্স দিস ইজ অ্যাবস্ট্রাক্ট সেই জন্য বাবুলালকে বললাম যে আমি ঘেঁটে গেছি তারপর আমার আর কিছু বলার নেই আমি কি পাচ্ছি অ্যাম্বিয়েন্স কী ছিল তখন আমার মনে হয় এখনও তাই আছে অসীম থাকলে ভালো হতো অসীম ঘোষ ডিরেক্টর আরআইও বা আমি জানি না এখন এই সময়ে কোনো যারা এক্সিস্টিং টিচার্স কেউ আছে কিনা যারা মেডিকেল ডক্টর সলিল মণ্ডল আছে আর যারা আছে একটু দেখে না আমি ঠিক চিনতে পারছি না তারা বলতে পারবে অ্যাম্বিয়েন্স কোনো আছে কি না আমাদের সময় কী ছিল কর্ডিয়াল ফ্রেন্ডলি ফাদারলি ইম্পার্শিয়াল পার্সোনাল পার্সোনাল মানে এমন নয় যে পার্সোনাল মানে আমার একটা উইকনেস আছে সেটা পার্সোনালি আমার টিচার বুঝতে পারলো এবং সেটাকে কারেক্ট করে দিল এটা 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 পার্সোনাল অ্যান্ড হ্যাঁ সেই জন্যই তো এতটা এসছি রে নাহলে এখানে দাঁড়াতে পারতাম গ্রেট ফেলোশিপ ইন অল লেভেলস ফ্রম গ্রুপ ডি স্টাফ to head of the department. And what is the ambience now? Amar mone hoy ami jetuku amar brief experience as a professor in ophthalmology in Kishanganj Medical College, same, cordial, friendly, fatherly, impartial and personal. 40 years ago, আমাদের কি অ্যাম্বিয়েন্সের মধ্যে কি ছিল? কমপ্লিটলি টিচার ডিপেন্ডেন্ট, নীল অর ভেরি রুডিমেন্টারি টেকনোলজি। স্লিট ল্যাম্প ছিল হেড অফ দ্য ডিপার্টমেন্টের ঘরে, উইথ খুব রেয়ার পারমিশনে আমরা ইউজ করতে পারতাম। কি সাবস্টিটিউট ছিল? লুপ। লুপ দিয়ে আমরা কিভাবে দেখতাম কেউ এক্সপেক্টই করতে পারবে না। আমরা এসপিকের সাথে কেপি কী করে তফাৎ করতাম উইথ লুপ, এখন কেউ ইমাজিনই করতে পারবে না। দেবা তো পারবে কি এখনকার দিনে এ করতে, এসপিকের সাথে এর ডিফারেন্সিয়েট করতে? অ্যাপ্লারেশন টোনোমিটার, আমি তো মনে করি না আমাদের এনআরএসে ছিল অ্যাপ্লারেশন, ছিল কি? ছিল না। সাবস্টিটিউট সিওস টোনোমিটার অ্যান্ড ডক্টর খারার ডিজিটাল টোনোমেট্রি। ফান্ডোস্কোপি, only direct ophthalmoscope, rare occasions BIO, একটাই ছিল আমাদের স্পেশাল এক্সামিনেশন রুমে। পেরিমেট্রি, জেরাম স্ক্রিন, গোল্ড ব্যান্ড পেরিমিটার অনলি ইন আরআইও। ফ্লুরেসেন্ট অ্যাঞ্জিওগ্রাফি প্রবাবলি অনলি ইন আরআইও, আমাদের এনআরএসে ছিল না। ছিল কি? অ্যাঞ্জিওগ্রাফি ছিল না, আরআইওতে ছিল। আরআইওতে ছিল তো কাবা, আমাদের এনআরএসে ছিল, এখনো নেই। আচ্ছা, ওসিটি not invented, research rudimentary, no computer, no internet, only RIO library and Haranda. হারান্দাকে কে কে রিমেম্বার করতে পারছে? আরআইও অনেকেই তুলবে হাত। হারান্দা, হারান্দার বই খুলে দেওয়া, একটা ইলিটারেট পারসন কি করে তোমাকে জার্নাল থেকে পেজ মার্ক করে বার করে দিতে পারে, দ্যাট ইজ স্টিল ইন্ট্রিগিং মি। যারা জানে, পড়াশুনো জানতো না। চা তো ছেড়ে দিলাম, আমি চার কথা কি করে যে বই বার করে দিত। দেবদাসবাবু আপনার এই আপনার রাখা আছে ওখানটায়। দিস ইজ অ্যাম্বিয়েন্স অ্যান্ড হাউ ইউ এক্সট্রাক্টেড ফ্রম দ্যাট অ্যাম্বিয়েন্স, ইট ইজ আওয়ার ক্রেডিট। লেভেলস অফ টিচার্স, কারা টিচার ছিল আমাদের? সিনিয়র টু আস বাই 1 or couple of years মেবি। বাবুলাল আমার একটু সিনিয়র লোক ছিল, মানে তখনও পিজিটি লেভেল ছিল। তার আমাদেরকে ছিল হিমাদ্রিদা, অনিমেষ দা, প্রসূন দা। তার একটু উপরের লেভেল কারা ছিল? অসীম দা, কাবাসী দা, গৌতম দা। আওয়ার ক্লাসমেটস, দেবা। আমরা কেন নিজেদেরকে নিজেদের টিচার বলছি? এক অড কোয়েশ্চেন ফ্রম দেবা, আই হ্যাভ টু গিভ দ্য অ্যান্সার, সো আই হ্যাভ টু রিড এ লট, গিভ দ্য অ্যান্সার নেক্সট ডে, ভাইসি ভার্সা। সো উই আর অল আওয়ার টিচার্স। দেবা, আমি, মানস। রিফ্র্যাকশন কার কাছ থেকে শিখেছি? কাবাসীদা, সন্তোষদা, তরুণদা। তরুণদা কেন বোধহয় তরুণ চক্রবর্তীকে দেবার মনে করলেও নিশ্চয়ই করতে পারবে। হ্যাঁ, তরুণদা। আচ্ছা, ওটি স্যাংটিটি, সাধনাদি, মলিনাদি অ্যান্ড আওয়ার অফকোর্স গ্রেট টিচার্স। এদের কাছ থেকে কি পেয়েছি না পেয়েছি সে তো অ্যাবস্ট্রাক্ট, আমি জানি। সুতরাং এটা আমার মনে হয় না সেরকম কিছু বলা যাবে। আমার মনে হয় এটা প্রেজেন্টেশনটা হতো, এটা অ্যাবস্ট্রাক্ট। এটা এবার এন্ড অফ দ্য স্লাইড, তো এবার যা বুঝে নে। এবার ঘেটে গেছি তো, আমি আগেই বলেছি আমি ঘেটে গেছি। এবার তোরা এসে উদ্ধার কর বাকিটা আমাকে। এই বাবুলাল, এবার তোরটা তুই বল। চলো, এসকেপ। থ্যাংক ইউ।
Thank you, Devdasa. So insightful lecture, and I'll like to request Dr. Devashish Bhattacharya for his talk. In between, any comments by Dr. D.N. Chattopadhyay? Any comments regarding?
No, it was a very good talk by Dr. Devdas Mukherjee. Today, in the audience, I don't see many people from the younger or the real students. So I think it's more of a nostalgia that we would like to carry forward. So in that spirit, I don't have slides, though I have to talk on the technology advancements in teaching. So to start with, I'll just narrate a few stories. Like today, you go on the YouTube and you search for any surgery that you want to learn, and that is available. Very good teaching stuff. But as Dr. Bokshi, my guru, he told that how we learned IOLs from him. So actually I went to another surgeon in those times, that was 86. I was not permitted to enter the theatre, and then I did not know Dr. Bakshi sir because he was not from Calcutta, but he allowed me, and I could stand by and watch the IOL surgery to an extent. When I started, because he said exactly, "Ar kotodin dari dari dekhbi, ebar mathe nam." So then with the Appa Swami microscope for 30,000 and 30 lenses, which were given free. So, and we could pay it over a period of time. That is why I value that gentleman, Dr. P.N.S. Appa Swami, so much, because we had no resource to buy a Zeiss microscope at that point of time. So upper loop insertion became a problem. I couldn't manage it properly. I told it to Bakshi sir, sir, এটা অসুবিধা হচ্ছে। বলে তুই এক কাজ কর, পরের পেশেন্টটা তুই মাইক্রোস্কোপ দিয়ে দেখ, all private patients and all high-end patients, আমি এমনি খালি চোখে করছি। So this is how we learnt. So that is technology today and how we did things back then. So I'll tell you another very interesting story that's around the microscope. So Devnada, we got some IOLs from WHO, Pharmacia lenses, acetylcholine, Myocol, and Helon GV, way back in 85. So you can well imagine the thrill, about 100 lenses. So, but we didn't know how to go about it. There was a microscope. Now we were operating on it, but you know, we were not very comfortable operating. So, don't spoil the story like that. So it happened, and we were struggling with it when Dr. Nagpal came to demonstrate vitreoretinal surgery. So I was there, it had a beam splitter. So I saw in the beam splitter that when Devnanda was operating, that I could see some image from a distance. So then I thought that I bought a big video cameras. Those video cameras were there. Every marriage house, you know, there were a group of people who to do marriage photography. So I caught hold of one guy and I asked him to place the camera there. And there was a wonderful video which came out. So then we went to Kalakar Street and we bought pipes. And me and Prithish is no more in Zeiss. So we placed it like that. And we could relay it in the RIO lecture hall from the operation theatre. So that was way back in 86. And sir came, we had kept a lot of cases, but he just picked up one or two very good vitreous hemorrhage eels type of patients. And there, you know, he was doing vitrectomy, and he said, yeah, this is the disc, this is the macula, so the eye is clean. We said we can't even see the anterior capsule clean cortex properly, and this gentleman comes and does this. We were absolutely shattered. So we didn't know what to do. But the real thing, Praduda has said, then I was doing IOLs regularly. One day I went, so Amolda was there. So Amolda said, oh, IOL surgeon eshe geche. Hey, kor. So he offered me one or two cases. And the students were there. I was again in the same mess. I couldn't, because that microscope I couldn't see again. Then I went down and asked Alokda that এই মাইক্রোস্কোপের কাগজগুলি আছে. So he somehow digged it out, and then I found it's a ENT microscope. So it had no coaxiality whatsoever. We were all operating on oblique illumination, and that didn't matter for the retinal surgeon because he was using his own, that's how Nagpal sir did the trick. And we needed coaxial, so I mean, that's how it ended up. So these are, those were learnings in those days, and then I'd say, I mean, Devdash was telling a lot about teachers of those days. I had two academically enrolled teachers, one, and I'm very fortunate to have them. I did my house job under Professor P.K. Chatterjee, and I was, as Devdash and all knows, more interested in canteen cricket and other things rather than academics. And I never, Devdash and actually he insisted, ki dekh etate surgery o ache, ekটু চশমা টশমা আর অভিজিৎ ঘোষ এমএস পেয়ে গেছে তো আমরাও পেতে পারি তো that was the basic funda of getting into ophthalmology. So I landed up as a house surgeon. I didn't know anything. And I remember in the very first day, the examination desk is still there in RIO, the high desks. So Professor Chatterjee saw one case, and then he jumped from the seat and said, Devashish, এটা দেখো classical codes, cholesterol crystals, exudative detachment, অমুক সমুক. I said, codes, forts, কি বলছে? I didn't know how to do ophthalmoscopy. And he was so intense, I'll tell you, he was so passionate about the whole thing that এরকম কেস কিন্তু আর পাবে না, এটা দেখে নাও, ওই করো. I said, okay. I mean, I felt so bad. I said, no, I mean, something must be done. Somebody is trying to teach me so eagerly, and here is me, a fool, who cannot even take that little thing from him. So, I mean, ophthalmoscopy কি করে শেখা যায়? তো পাশেই রিফ্র্যাকশন রুম ছিল, কাবাসিরা বলল, ওখানে চলে যা, সব ডাইলেটেড পিপল, অপথ্যালমোস্কোপ দিয়ে দেখতে পাবি. So, yes, okay, I mean, we could see through the ophthalmoscope. Then undilated pupils, how to do direct ophthalmoscopy. So this is how we learned. Then, how to fast track things. We used to quiz ourselves like, এই distant direct ophthalmoscopy তে এইটুকু cataract দেখা যাচ্ছে, তো ওর vision কত? তো ওর vision এত হতে পারে. Like, I don't have the youngsters here, but I would say that, this is the best way to learn, that you quiz yourself, যে এই OCT তে আজকের দিনে, this OCT can have what vision? So this OCT can have this vision. Then you have a very good understanding of the OCT and the functionality and the evolution of the pathogenesis of a particular disease as it goes, and the OCTs that it gives along the way. So, I mean, এই জিনিসগুলি were fantastic. I will lastly conclude with one story from the biggest guru, the legend of ophthalmology, which many of us have shared and but I was very close to him, Professor I.S. Roy. So we were the first batch of students who, in the entrance, there was a written test, and whoever scores, but the first time we could choose our teachers, like who's going to be my thesis guide or where will I do, according to your ranks. So somehow I topped. So I asked everybody, no, I mean, no choice, go to Professor I.S. Roy, RIO, that's it. So even Professor P.K. Chatterjee said that, so I landed up there. So Professor I.S. Roy, Pannada and all will endorse. Those days he was surrounded by 10-15 people, RMO, RS, house staffs and everybody, and like we are all peripherals. So I went and he said, so Tumike, I said, I wished him good morning, sir. I'm the new PGT in the department. তো আজকাল তো তোমরাই ঠিক করে নাও কে কার আন্ডারে এমএস করবে, বিকজ we were the first batch. So I said, I didn't answer him anything. I just kept quiet. And then he walked away. And with the kind of engagements he had, about 400 patients in the OP, 30, 40, 50 surgeries in the operation theater, he could ignore me anytime. I mean, he could look through me, he could do anything. So the next 7 days, I was just moving around him, and I didn't know what to do because he wouldn't talk, he wouldn't assign me anything, so I was just moving around him. And then I was actually a little worried, so I went to Pannada, and I said, Pannada, কি করবো? তো বলে তুই ঘুরতে থাক হ্যাঁ আর সকালে 8:45টার মধ্যে চলে আসিস ঘুরতে থাক পেছনে থাক. So I said fine. But then on the 8th day, which Monday and the next Monday, he had his WME white ambassador, so that came. So somebody used to open the door and he used to come out. So somebody went, he said like this from the car, and then he called me, so open the door. So I opened the door, and he stepped out, and he said, and then he put his arm on my shoulders and said, কি খুব feudalistic লাগছে? No sir, I'm from a defense background, so it's okay with me, sir. But no, there's a very good point to it. This ensures that you come to the department before I do. So unless somebody opens the door, I don't get down, and usually it is the postgraduate who does this. Lessons learned, okay. So then he asked me, কোন কলেজ? নীলরতন. তা নীলরতন মানে কি কলেজ? মানে মেডিকেল কলেজই তো কলেজ, আর কোনো কলেজ নেই. তো এরকম একটা অ্যাপ্রোচ ছিল কথার মধ্যে. তা আই সেড কি না, এটা অনেক হয়ে যাচ্ছে. তো আই রিসর্টেড টু মীনাক্ষী, ও স্যারের মেয়ে. বললাম স্যার মীনাক্ষী রয় আমাদের এনআরএসেই পড়ে. তো বলে হ্যাঁ ওখানে পড়ে. হ্যাঁ. So anyway, that finished. Then he said that এর পরের 1 মাস তুমি সব সময় আমার পাশে থাকবে, কোথাও কোনো জিনিসে সই করবে না, কিছু লিখবে না, কাউকে কোনো কথা বলবে না. And I tell you what, in 1 month I could understand absolute ophthalmology. Though I had learnt in house job, I did a pretty good house job under Professor P.K. Chatterjee. I was quite okay with my knowledge at that time, whatever I was, to take up the MS-ship, but that was a real learning. And then after 1 month, he asked, you sit there, the next seat, and you can see. So this was real mentorship for me. Today, we don't have juniors today, but what I could feel, what I really feel from what is not right, probably it's a wrong practice, that the house job, this house job thing is very important. Like today, during the internship, which is the first clinical exposure of from academics to practice, they are busy, the young generation is busy preparing for the PG exams. They don't do their internship, they can't do their internship properly. And then based on the results of the PG exam, so they are about 1 lakh MBBS, and then you boils down to 65,000 postgraduate seats, of which some are not worth doing, or the places are not worth doing. So in that they choose. But I think, at that level, after just reading academics and not being in the wards, it becomes very difficult to make a choice whether you really want to do that subspecialty, because that is a very, very major decision. And I think the house staffship culture actually exposed us to, get ourselves oriented and take us forward in that direction. And I sincerely feel that this is a very, not a very good practice. and we should at least voice it over so that, and these unnecessary fellowships, like when we passed out and we had to go into practice because we didn't get a government job, me, Devdas and all of us, Arup Chakraborty. But it all, we were fine because another important, when ISRAর গল্প বললে শেষ হয় না, so I'll just give you an administrative lesson or story from ISRAI. So one day he used to walk into his corner director's room and then come out, and then we go for the rounds or then to the operation theatre. So while we were on the rounds, on the way he asked, hey, A flat-er phone ta thik ache ward e? Probably he was calling, he didn't get it. Oh, then he said, oh, no, ward duty ta to tomar, it's not a part of your job. Then in the ward he came, when he went to the A flat, he said, call the sister. So I called the sister. তো সিস্টার একটু নিচে ফোন করুন তো যে পান্নালাল শাহ এসছেন কি না, বিকজ ইট ওয়াজ 9 বাই দ্য টাইম, এভরিবডি শুড হ্যাভ বিন অন দেয়ার ডেস্ক অ্যান্ড জব। তো সিস্টার তো চলে গেল, তখন আমাকে বলছে ও চলে গেল তার মানে কিন্তু ফোনটা ঠিক থাকা উচিত, এখন যদি ফিরে এসে বলে যে ফোনটা ঠিক নেই তাহলে কিন্তু আমি ওর কাপড়টা খুলে দেবো। সো ইউনো, the only thing he wanted to know is the phone ta thik ache kina. So suddenly sister দৌড়ে দৌড়ে আসলো, স্যার পান্নালাল শাহ এখনো আসেননি। ও তাই নাকি, এখনো আসেননি? ওকে, আচ্ছা ঠিক আছে। তো তারপরে আমাকে বলছে পান্না এখন আন্দামানে ক্যাম্প করছে, তা তুমি দেখলে সিস্টারকে? আলাম হ্যাঁ। তো বলে 9টার সময় আসেনি, কীরকম খুশি হলো, তা ওদের মধ্যে কিছু একটা প্রবলেম আছে বোধহয়, যাই হোক তাতে আমার কি। So like this was the kind of HR and whatever administrative feedbacks he used to, I learned a lot from him. So thank you. I think we all wanted to hear these stories, so I shared with them. Thank you.
I would like to invite our last speaker, none other than Dr. Obhijit Ghosh. Mike.
Devnath has been talking about Dr. I.S. Roy. I just want to add one word. He was very particular about the cleanliness. He used to walk into the toilet while going round the wards to see whether they have been kept clean or not. This is one thing I want to add.
Good afternoon. I thank all these young boys for insisting that I should speak on a subject very peculiar. Attitude is everything. প্রথমেই এসে দেবুদা বলল আমি নটোরিয়াস ভগা, মানে দেবাশিসকে বললো কী করে বাবুলাদা যেমন চান্স পেয়েছে আমিও পাবো। প্রদ্যুৎদা বললো তোর 70 বছর বয়স হয়েছে, বাট মাই অ্যাটিটিউড ফিলস দ্যাট ইজ অল ইন আ পার্ট অফ দ্য গেম। দিস ইজ দ্য বেসিক অ্যাটিটিউড অফ এনজয়িং দ্য হোল থিং। সো যখন অ্যাটিটিউডের কথা বলা হয়েছে, দিট ইজ আ ভেরি পার্সোনালাইজ ব্যাপার। মাই অ্যাটিটিউড উইল ডিফার ফ্রম ইয়ার্স। তো আমি রূপককে বললাম, রূপক বললে আপনার অ্যাটিটিউডটাই শুনি। দ্যাটস ফাইন, লেটস গো অন। This is myself. So আমি প্রথমে ডিকশনারি খুঁজলাম, what does attitude mean? অক্সফোর্ড ডিকশনারি বলছে it is a way of regarding things, যে চোখে দেখি আমরা। So this is a very important book which I have read. It is written by Jeff Keller. Attitude is everything. This is, please, at your off time, please go through this book. This is a wonderful manuscript. So I thought যে বড় বড় লোকের অ্যাটিটিউড সম্বন্ধে কী বলেছে। তো আই ফাউন্ড আউট হোয়াট উইনস্টন চার্চিল সেড। উইনস্টন চার্চিল বললো অ্যাটিটিউড ইজ আ লিটল থিং দ্যাট মেক্স আ বিগ ডিফারেন্স। হোয়াট ডিড আইনস্টাইন সে? weakness of attitude becomes weakness of character. So attitudes basically is indigenous to everyone. I can talk about my attitude only. And what is my attitude? You see the attitude difference? কোন লোকটাকে ভালো লাগবে প্রথমে? Donald Trump, and you see the man after 3 decades of jail. You see the facial attitude. What a difference it makes to you. Then you go to the next. Attitude of the gentleman. I have been following cricket. See attitude of Virat Kohli. At least last time he said that my ego was spoiling me. You see his attitude, and see Rohit Sharma. What calm but aggression. There are two different things altogether. I hope you are enjoying it. So attitude, how do you develop attitude? One is the upbringing. For myself, I can say I was bred in a North Calcutta conservative family, joint family, where we were taught to live with each other. And that was the basics of my attitude of adjusting and to everything, trying to adjust. That is a very important thing, how you are brought up. Our college was a very important part in that. We were together. For a whole time, as everyone has said, sports has been a game changer in my life. A sporting attitude, especially collective sports. We used to go play football. 11 জন খেলছি. One is being hit. আমাকে একজন মারলো। দৌড়ে এলো আমার রাইট ব্যাক, বললো তোকে মেরেছে আমি ওকে মারবো। It's just a simple thing, but it gives that I think for yourself. You are thinking for yourself. That is so you must have an extracurricular activity. Music, Devuda. You see Devuda fantastic নাটক করতো। বুদবুদ বলে ওদের গোষ্ঠী ছিল কলেজে। তার জন্যই আজকে করছে। You see, that is keeping him going. খুব ইয়াং বয়সে দেবুদা ছেড়ে দিয়েছে, কিন্তু হি ট্রাভেলস, নাটক করে। দ্যাট ইজ আ ওয়ে অফ লাইফ অলসো। মিউজিক, অল দিস থিংস আর গেম চেঞ্জার্স ইন লাইফ। দে উইল টিচ হাউ টু অ্যাডাপ্ট ইউর সেলফ টু ডিফারেন্ট সিচুয়েশনস। Students' Union has been a very important part. You know, I've been involved in social, I'm a president of a very premier club of Calcutta. You do not know, I will always believe that the persons who have done Students' Union, they are the best performance in late life, because they are taught to think for others. So I think Students' Union, you know, Rotish Pal was a famous Students' Union leader in Bangla Medical College. Devashish and all, we were all Students' Union stuff. Sports is very important because my friend Devdas Mukherjee, he tried to play table tennis. He couldn't beat me any in his life. He tried. He still tries. So what is attitude in me? The first person I thank, so I read, this is my attitude. There are more things in the heaven and earth, Horatio, than are dreamt in your philosophy. This is what Hamlet said to Horatio. When Hamlet was walking with Horatio, the walkman said that your father's ghosts are moving around. Hamlet believed it, Horatio didn't. So this is what he said. There are more things in the world than it is in our own philosophy. This is a very important. এটাতে রবীন্দ্রনাথ কি বললেন? চারিদিকে দেখো চাহি হৃদয় প্রসারী, ক্ষুদ্র দুঃখ সব তুচ্ছ মানি, প্রেম ভরিয়া লহ শূন্য জীবনে, look beyond yourself. This are the philosophy which has changed and they keep on my life. This is a person, my father, he was an ophthalmic surgeon. He was trained with Professor Carl Linder and Pillat. You see the middle picture. I am on the ear of my grandfather, and in the clinic, Linder is sitting. He was not a passionate ophthalmologist. He did not like ophthalmology. He was into music, he was into sports, he was in literature. I am more passionate about ophthalmology, but I have inherited his gene, so I have been a passionate footballer, cricketer, and sportsman and writer altogether. This person has basic impingement in me that life is not only about a profession. Teaching. I always believe teaching has been a gurukul. It is always in life. Whatever you do, you learn from your teachers. This is gurukul. Teachers have been taught. Teachers were our role models in our days. As Devashish said, they were mentors. Importantly, they were the usherers to the outside world. I went to Calcutta Club first with my teacher, Professor I.S. Roy. He was not only teaching me ophthalmology, he was teaching me to the world. He was pushing me to the world. That was more important. As you can remember, outside Medical College, Eden Hospital, all the big cars were standing. And we used to adore those people, that they were from the outside extraterrestrial world. This is the way we tried to follow him. They were modulators in life and character. They molded your life and character. They changed the conception of your life, how to treat with patients, how to behave externally, how to be a good doctor. These are all the things. Ophthalmology can be taught by anyone, any subject. But the other things which was related to the house staffship period were something magnificent. They have taught us. Character development. He was talking about I.S. Roy. I can tell you one story. When we were operating a patient, sir was operating, some problem had, thing has fallen down. So one of the said ish. After the operation, there was his he said, after the patient has gone, he said, you know, it will be a very good operation, okay. But jodi kono problem hoy, oi ishta will be the factor that something had happened because you're operating on a patient who is on local anesthesia. This was a learning which, so I would suggest never talk inside the OT, especially ophthalmologists, because you are being heard by the patient. Your operation may be everything, you're doing hundreds every day, but that is what Ayasrai told me. It is his once in a life experience. And this experience he will dissipate not only to his family, but the whole of the community that this has happened. So he taught me this. Ethics, he taught us. Because you know, every teacher of theirs, most of the teachers were very ethical those days. Ethics was a thing we learned teachers. But I will tell you, the relation was respectful, but sometimes very fearful. Because there were many teachers for whom many careers have been spoiled. There are many people whose careers have been spoiled. So it was a respectful, fearful relationship. That is what I think about it. Teaching then was basically clinically based. We had to believe in Gurukul. Ami Anita di jane, Dr. Kamalesh Bardhan deke bole diyo 17.6, 18.2, tai na? It was based, and we used to believe that. We also developed that. So it was basically what he said was the last word. But now it is much more evidence-based. What he said, everyone in medicine, surgery, we were taught to palpate the skin, liver, anything. And they didn't have any ultrasounds, but they were perfect, absolutely. Clinical meetings, I have to say certain things. This was clinical-based. It was completely dominated by teachers. The students had got no scope whatsoever. And it was sometimes a very delicate situation between teachers fighting with each other. And we were just onlookers. So this was the thing which happened. Ego and dogmatism were important factors. Not with everyone, but certain people. We have seen them. Clinical meetings now are much smarter, high standards, more sponsorship oriented. But I am worried about one thing, poor patients. 10 operations, 10 anti-VEGFs, 20 trifocals, focals. Who pays for it? What about those pure patients? You are giving 10, 12, lagao direct anti-VEGF. More, go on giving it. But we are not concerned with the economics of the patient at all. This is my concern. Surgical skills, phenomenally improved. What Rupok and people, all these, Saurabh, all these people have done, wonderful. We were the starters, but you are doing a wonderful job. But one is important. You can still survive at the highest level as an academician, which we could not do that days. Oi dine surgery na janle ta kauru were not accepted as an ophthalmologist. I can remember many people who were not surgeons. Kintu ajke see Jyotinmoy, our friend, he has flourished. He's a world which will never have happened in Calcutta. So this is one thing we should be very proud of. This is a very important thing which everyone agrees to us. We were brought up with the concept of respecting the successful clinical practitioners. Jader gadi ache, practice ache, taderke amra সম্মান করেছি. We sacrificed academicians. I will give you some examples. First, Professor Subhash Mukherjee. Ajke je IVF follow kora hoy, it is the technology followed by Professor Subhash Mukherjee. ওই সময় নীলরতনের অ্যানিমাল হাউসে বসে গড়ে করেছিলেন একা. Then he went for a clinical meeting in, I suppose, Chittaranjan Cancer Hospital. And the way he was demoralized, by his colleagues, and those colleagues were clinically very significant. তারা ক্লিনিক্যালি সিগনিফিকেন্ট। তখন সুভাষ মুখার্জি was frustrated. He was transferred to Bankura Medical College, finally RIO in the electrophysiological department. আর তাই তো RIO, and হ্যাঁ non-existent. And this person, আমি যখন NRS এর প্রেসিডেন্ট ছিলাম, I had a commemoration meeting on him where Durga came, the girl who was his first IVF. 10 days after the initial IVF হয়েছিল ইংল্যান্ডে, দুর্গা told me, স্যার উনি আমার ভগবান, উনি কোথায় কাজ করেছিলেন, আমাকে কোথায় ভেবেছিলেন, আপনি একটু নিয়ে যাবেন অ্যানিমাল ফার্মটা। আনফর্চুনেটলি অ্যানিমাল হাউসটা ভেঙে গেছে। বাট দিস গার্ল ওয়াজ ইন টিয়ার্স, অ্যান্ড দিস পার্সনকে আমরা কোনোদিন করিনি। দিস ওয়াজ দ্য প্রবলেম ফর আস। দের আর আদার এক্সাম্পলস জেন্টলম্যান অফ দিস। প্রফেসর জ্যোতির্ময় বোস, আপনারা কেউ নাম শোনেননি এখনকার দিনে, আমি জানো না। আনঅ্যাজিউমিং ম্যান, ওয়ান্ডারফুল ম্যান, হি ওয়াজ দ্য টোটাল অ্যাকাডেমিশিয়ান। হি হ্যাজ ডান আ ওয়ার্ক, যেটা নিয়ে আমি কাজ করি এখন। পিকফোর্ড অ্যান্ড জ্যোতির্ময় বোস, কালার ভিশন অ্যান্ড এস্থেটিক প্রবলেমস ইন রবীন্দ্রনাথ পিকচার্স, ওইখান থেকে আরম্ভ হলো রবীন্দ্রনাথ ওয়াজ আ প্রোটানোপ। This is one of the works of Jyotirmoy Bose. He was posted in Bankura. He was working with achromatopes, total color blinds. This, আমি শান্তিনিকেতনে গেছি, আমি কেতকী কিশোরী ডাইসনের সঙ্গে কথা বলছি, ইউ ডু নট নো হোয়াট রিগার্ড দিস ম্যান হ্যাজ, কিন্তু আমরা তাকে চিনি না, বিকজ হি ওয়াজ নট আ গুড ক্লিনিশিয়ান অ্যান্ড আ প্র্যাকটিশনার। আনফর্চুনেট, এখন সেটা হয় না। নেক্সট, দিস ইজ আ অরিজিনাল পেপারটা। আমি জানি অনিতাদি, জ্যোতির্ময় বোসের মেয়ে হচ্ছে অনিতাদির ক্লাসমেট, তাই তো? বাড়ির সামনে চন্দ্রনগর। সেকেন্ড হচ্ছে দিস ম্যান, জেনোনাক ফটোকোগুলেশন আমায় শিখিয়েছিলেন প্রফেসর সৌরেন সেন, আমার কো গাইড ছিলেন। আনঅ্যাজিউমিং, প্র্যাকটিস ছিল না, ওয়ান্ডারফুল লোক, কেউ পাত্তা দিত না রাইওতে, in the same as the clinical big shots. But he is the person who taught me all these things. He is the person in 1983 presented a paper with me for an insignificant postgraduate, gold as an intraocular body in British Journal. He was the person who did it. And I am always grateful to him. This was the picture he took, তখনকার দিনে, as a fundus photograph he took. He initiated me to this. So this আরেকজন ছিলেন প্রফেসর অমল ব্যানার্জি, কেউ পাত্তা দিতেন না, বাট হি ওয়াজ অ্যান অ্যাকাডেমিশিয়ান। হি উড হ্যাভ শান এভরিওয়্যার, কোথাও চললে হি ওয়াজ ডান আ গ্রেট জব। মাই রেসপেক্টস টু অল অফ দেম। প্রফেশনাল রিলেশনশিপস এখন ইট ইজ মাচ বেটার। তখন ছিল, কিন্তু অতটা ভালো ছিল না, যদিও তখন উই ওয়াজ সেভড, ওখানে কনজিউমার প্রোটেকশন হয়নি, নয়তো কত যে হতো তখনকার দিনে শেষ নেই। এই অপারেশন খারাপ করে দিয়েছে, ভালো করে দিয়েছে। রেয়ার পিসেস ওয়ার দেয়ার, লাইক প্রফেসর আইএস রায়, দে নেভার ইউজ টু টক। বাট ইন জেনারেল প্রফেশনাল রিলেশনশিপ এখন যা রিলেশন দেখি এখনকার ছেলেদের মধ্যে, it is much, much better, and we are very proud of that. Personal touch has gone down. We were directly related to the patients. I will give you much more examples. Personal touch, you do not see the patient, you believe in numbers, 30টা cataract, 40টা অ্যান্টিভিজেপ, তার বাড়িতে কী হচ্ছে জানো না, কিছুই জানো না, ইটস নট পসিবল ফর ইউ টু নো। কিন্তু এখনও we have people, persons coming on only for personal touch. So it is a request to juniors, ওরা পেশেন্ট, ওরা দরকারে তোমাদের কাছে এসছে, ট্রাই, আই নো ইউ আর বিজি, পার্সোনাল টাচটাকে ভালো করার জন্য। দ্য গেম চেঞ্জার হ্যাজ বিন ইকোনমিক্স। দেবুদা যেটা বললো, আমি লেকচারার, দেবুদা অ্যাসিস্ট্যান্ট প্রফেসর, প্রদীপদা আমরা দিল্লি যাচ্ছি 3 টায়ারে করে, তাই তো দেবুদা? যাচ্ছি, এটা কোনো এক্সপেক্ট করা যায় না। ইকোনমিক্স হ্যাজ চেঞ্জড, বিকজ ইউ পিপল দিস ডেজ, ক্রিকেটারদের মতন, ইউ ক্যান কম্পেয়ার ক্রিকেট, জগমোহন ডালমি হ্যাজ চেঞ্জ দ্য প্রোফাইল অফ ক্রিকেট, সেরকম একটা গেম চেঞ্জিং হয়েছে। ইউ আর মাচ বেটার অফ দেন আস, হোয়াট উই ওয়ার, বাট উই ডোন্ট রিগ্রেট, বাট দিস ইজ আ ফ্যাক্ট। This is a person who's changed. I will talk to you some persons who have been a game changer in my life. This person. This is a wonderful person. যেটা বললো দেখে করতে, when we went for training for him, he was a different man. A man practicing in Jaipur. 40 বছর আগে একটা রেটিনা ক্লিনিক খুলছে in Ahmedabad. Only retina. It was not heard of. And when I saw the man, কাজ করছে তখন কাজের পরে he's taking me to his, sorry, এক মিনিট, he's taking me to his home, গজল গান গাইছে, ড্রিঙ্ক করছে, কথা বলছে, all jokes. He brought a different perspective to our life also, actually. So I am grateful to him. The other two persons are not basically doctors, but this is Pezda. Pezda was our senior. Pezda আমার মনে আছে, এটা সবাই দেখেছে পেজদাকে। পেজদা যখন ক্রিকেট খেলতো আমাদের মাঠে, আমাদের সঙ্গে খেলা ছিল শিবপুর বি কলেজের। তার দুদিন আগে পেজদা বার্সেলোনাতে ওয়ার্ল্ড কাপ খেলে এসছে। শিবপুরের মাঠে হি ওয়াজ দ্য ফার্স্ট টু গো 9 o'clock. Unassuming man, I am very proud of Pezda. And this person, Pradipda, whatever I was close to him, I spent with the man, everything was positive about him. Everything was positive about him. The way he talked, what vocal tonic as you call it, I am very indebted to this man. Also this man, Chunida. একদিন আমাকে বলছে, দেখ আমরা সকালে হাঁটছে, বলে দেখ আমরা সবসময় যখন বাইরে যাই, বেড়াতে যাই, আমরা যাই হোটেল থাকি, আমি কি করি জানিস, খুঁজে বেড়াই কোথায় পার্ক আছে, ওখানে দৌড়বো। তাই তো আমি চুরি করছি, আমি বলছি আবার। তো দিস আর দ্য লার্ন থিংস উইচ লার্নড। অ্যান্ড দিস ম্যান কিছুদিন আগে, এর নাম হচ্ছে মণিশঙ্কর চ্যাটার্জি, শঙ্কর। ক্যালকাটা ক্লাবে আমি ওর ইন্টারভিউ নিয়েছিলাম। আমার ইন্টারভিউয়ের পরে আমি একটা ছোট্ট গল্প বলি। ক্যালকাটা ক্লাবের একটা রুম নাম্বার 7 আছে। সেই রুম নাম্বার 7-এর সিগনিফিকেন্ট বিকজ ওখানে বারওয়েল সাহেব থাকতেন, দ্য লাস্ট ইংলিশ ব্যারিস্টার। অ্যান্ড বারওয়েল সাহেবের প্রত্যেকটা ব্যারিস্টারের একটা করে বাবু থাকে। শঙ্কর ওয়াজ ইজ বাবু। ওইখানে থাকতেন, রোজ কোর্ট থেকে ফিরে ওই শঙ্করকে ডিকটেশন দিতেন। আর শঙ্কর ওই থেকে লিখে ওর প্রথম বইটা কত অজানার ওইখানে লেখা। সো মণিশঙ্করবাবু আমায় বললেন যে খুব ভালো লাগছে ঘরে বারওয়েল সাহেব, আচ্ছা ডাক্তারবাবু আরেক যদি বাঁচি তাহলে আরেকটা স্যাটাবোসে লিখতে পারি বলুন। অ্যাট দ্য এজ অফ 93 হি ইজ টেলিং মি আরেকটা স্যাটাবোস লিখবো আমি। সো দ্যাট ইজ হোয়াট অ্যাটিটিউড ইজ। সো gentlemen, for seniors, if you have the options to enjoy your late life like we are doing it, other than medicine, কি করতে পারো? রেসে যেতে পারো আমার মতন, ক্যামেরা নিয়ে ছবি তুলতে পারো, or you can play cricket, or you can have a glass of beer. If you build a proper future legacy. The question is, you have to build a proper future legacy and accept the law of life. আমাদের বয়স হচ্ছে, আমাদের চেয়ে আমাদের জুনিয়ররা যে ভালো, এই কনসেপ্টটা মনে ঢোকাতে হবে, তাহলেই ভালো থাকবো। সো দিস ইজ হোয়াট উই আর অ্যান্ড নাও। সেম থিং, ক্রিকেট খেলতাম, এখনও খেলি। দ্য গ্রেটেস্ট স্যাটিসফ্যাকশন অফ এ টিচার ইজ ওয়েন দ্য স্টুডেন্ট আউট পারফর্মস হিম। দ্য গ্রেটেস্ট স্যাটিসফ্যাকশন অফ দ্য স্টুডেন্ট টিচার ইজ আউট পারফর্ম হিম। সো লেট আস ট্রাই টু বি পার্ট অফ দ্য জার্নি অ্যান্ড নট বি অবস্টেকলস। কাউকে যদি জীবনে বড় হবার হয় না, সে আপনিই হবে। কিন্তু ওর পথে যদি আমি একটু হেল্প করি না, চিরকাল মনে থাকবে। আর ওর পথে যদি একটু গোলমাল কাটি করি, তাহলে ও আমাকেও ঘেন্না করবে। সো লেটস বি আ পার্ট অফ দিস স্টোরি অ্যান্ড হেল্প দেম। বি প্রাউড অফ ইউর জুনিয়র্স অ্যান্ড দে উইল টেক কেয়ার অফ ইউ। আমি জানি আমার মনোময় জুনিয়ররা আছে, আমার রতীশ আছে, ওই জন্য ওরা আমাকে প্রেসিডেন্ট করেছিল। বিকজ I take care of them, they take care of us. I am very happy. And people like Rupak, everyone, I am very proud of you people. So, as the New Testament says, as you sow, so shall you reap. তুমি যা করবে তার ফল পাবে জীবনে। দুটো গল্প বলছি। এই মেয়েটি এই বয়সে রেটিনোব্লাস্টোমা ছিল 23 বছর আগে। এখন মেয়েটি সুইডেনে থাকে। লাস্ট উইকে আমার কাছে এলো, একটাই চোখ, ওর বিয়ের কার্ডটা নিয়ে। কামস উইথ মি। এরকম অনেক গল্প আছে, এটা আমাকে খুব টাচ করেছিল। দ্য নেক্সট ইজ দিস। এই মেয়েটি যে বসে আছে কোলে নিয়ে, ও যখন বাচ্চা হয় আমি 2 চোখে অপারেশন করেছিলাম, ওর মেয়েরও কনজেনিটাল ক্যাটারাক্ট হয়েছে, বিহার থেকে এসছে। অনেক হতে পারে, ইউ ক্যান আর্ন লটস, পোর্শেস, শেভরোলেস, মাল্টি স্টোরেড, এভরিথিং, বাট এই আনন্দটা কে দেবে? হু উইল গিভ ইউ ইন লাইফ? হ্যাভ ইউ এভার থট ইট? So all you doctors, genius, তুমি আজ যা করেছো না, you will get that fall. It is not in form of money, it is not important, it is a form of inner respect, which is very important to our lives. In addition to knowledge, you need passion, compassion, honesty, philosophy, and above all, spirituality. At the end of the day, we are answerable to two things. One is our conscience and our patience. This is what also ISRA taught me. This is a very interesting slide I love from Sound of Music. Nothing comes from nothing. Nothing ever could. So somewhere in my youth or childhood, I must have done something good. And this is a very famous Audrey Hepburn. She was told about nothing is impossible. She replied, the word itself says I am possible. So everything is possible in life. And this is a very পুরনো ছবি আমি জোগাড় করেছি। বীরেন শাহর সঙ্গে আমরা দেখা করতে গেছিলাম 2001। প্রদীপদা চিনতে পারছো? চণ্ডীদা, প্রদীপদা, all are there. Romenda, all are there. So thank you all for your patient hearing. Thank you very much.
Thank you, Dr. Abhijit Ghosh, for a wonderful talk. We are running very late, so I will call Dr. Sangeeta for last talk. Can you please keep your talk very short?
So, good afternoon, everyone, and pranam to all the senior ophthalmologists here. I'll just take 5 minutes. I thank you, Dr. Debashish Das, for giving me the time to introduce our group to everyone. So, this is a group we have developed for sharing our stories. Where may I please request Dr. Abhijit Das, Dr. Doel Bishwas to please come on the dais, and Dr. Parag Mukhopadhyay. These are the core committee members. Along with me, Dr. Parag Mukhopadhyay is here, Dr. Abhijit Ghosh is there, Dr. Pushpita Sahu, Dr. Debashish Das, Dr. Tulika Ghoshal, Dr. Rajesh Mujumdar Chaudhary, Dr. Doel Bishwas, and Dr. Shantanu Mondol. So why this committee has been formed? Because as we know, 1 in 5 people experience mental health condition, and we suffer because we don't talk about it. So here we have formed this group to share our story and spread the word. What do we feel? We feel sad, we can't sleep at night, we have low energy levels, we have panic attacks, we have mood swings, we have emotional eating, and many other problems which we try to ignore. We say, Acha, this is a passing time and it will go, but most of the times it doesn't go, and we keep on suffering. So we have formed a support group where we are approaching people to come to approach us, to talk to us, and it will be a safe haven, because it will be a non-judgmental group discussion with the people who want to come to us and talk to us, and it will be a private and the privacy and confidentiality of the people will be maintained. It will be a support group for caregivers. I will take just few seconds, because as a caregiver of some patients, I understand that giving care to mental health disorder patients it takes a toll on the caregiver also. So we will form a support group for the caregivers also. We have few psychiatrists with us, like Dr. Rima Mukherjee and Dr. Aloknanda Dotto, and we are talking to few more people to join us in this endeavor. And we will soon come up with a helpline number. For now, this is my number, and people can approach me if they need any help. We have few strategies in mind to organize seminars and webinars with psychiatrists and psychologists to create awareness. And we will invite all the family members of our OSWB members for our webinars and seminars, and we will have support meetings. Our first webinar will be held on 27th of July at 8 p.m. Thanks a lot, and we support from everyone for this endeavor. Thanks a lot.
Thank you, Sangeeta. Now we close this session. I would like to invite our secretary, Dr. Debashish Das, to come in the dais and to start the felicitation program.
Thank you, Dr. Arup Bhomik. I'll use the floor, because they'll be putting up the stage. So better I'll use the floor over here. Before we embark upon the mementos for our seniors today, last year we missed many of our seniors for the awards, for the Lifetime Achievement Awards, and for the Presidential Medals. So initially, I would like to distribute these medals before we embark upon the mementos. Last year, 2023, OSWB Lifetime Achievement Award was given to Dr. Brojendra Kishore Sarkar. Sir was not well at that time. I thank you, sir, for attending the meeting today. May I request our Vice President, Dr. Arup Chakraborty, to please, President-elect Dr. Arup Chakraborty, to please honor Dr. Brojendra Kishore Sarkar. Yeah. This is the presidential medal that we had given last year. Sir was not there, so this is the presidential medal for him. Shawl. May I request Dr. Anita Banerjee, madam? We had the medals for the secretary as well as the president we distributed last time. May I request Arup, please, to give you the honors. Thank you so much. Thank you. May I request Dr. S.N. Roy to please come. Sir was the president of our society. This is the presidential medal for sir. Thank you so much. And the last one, Dr. Meeta Khan, madam. She was the secretary 2002-2003. Thank you, madam. May I initiate the mementos for today now? Dr. Ashim Kumar De, sir. Book it up. Next. The other. Dr. Arun Gupta. একটু এগিয়ে যাও, একটু এগিয়ে যাও, আমার দেখতে সুবিধা। ডক্টর অনিতা চ্যাটার্জি, ডক্টর অঞ্জন বাগজি, ডক্টর অসীম চক্রবর্তী, ডক্টর অনিতা ব্যানার্জি, একসঙ্গে দিয়ে তিনটে দিয়ে তারপরে ছবি তোলো, তা নাহলে না টাইম বেশি লাগছে। হ্যাঁ না ঠিক আছে, ছবি উঠছে তো তাহলে। আচ্ছা, ডক্টর বিতেন বৈদ্য, ডক্টর বি কে সরকার। হ্যাঁ স্যার আপনি ওখানেই বসুন, ওখানেই আমরা পাঠিয়ে দিচ্ছি। হ্যাঁ একটু তুমি বাইরে এসে ছবিটা নাও। ডক্টর বিজয় বড়াল, হ্যাঁ স্যার আপনি ওখানেই থাকুন, আমরা দিয়ে আসছি। আরে বিমল চক্রবর্তী তো। আচ্ছা কই 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 ডক্টর দেবনাথ চক্রবর্তী নিয়ে যাও, দাঁড়িয়ে যাও। ডক্টর দেবনাথ চ্যাটার্জি, চাদর দাও। ডক্টর এ কে মাইতি, ডক্টর অজয় মুখার্জি, ডক্টর অজয় মুখার্জি স্যার একটুখানি ওই দিকটায়। এই নে এটা ধর। প্রফেসর এ আর ব্যানার্জি, স্যার আপনি ওখানেই থাকুন স্যার, আমরা যাচ্ছি। হ্যাঁ যাচ্ছি, অরূপ চলে যাও। ডক্টর অসিত বরণ সাহা, স্যার ওখানে দাঁড়ান, আমরা যাচ্ছি। আমার এখান থেকে লিঙ্ক কেটে যাবে, অরূপদা নিয়ে যাও, অরূপদা নিয়ে যাও, ছবি উঠবে। হ্যাঁ তোমরা যাও, যেতে থাকো। তারপর ওই বাবুলাল তো কই, ওই যে সামনে বসে। ডক্টর অভিজিৎ ঘোষ।
আমি একটা লেকচারে বলতে ভুলে গেছি, আর কিছু না, আমি খালি দেবাশিসকে বলছি আজকে সন্তোষদা থাকলে খুব খুশি হতো যে গোবিন্দটা মানুষ হয়েছে, একটু এতটা সুন্দর প্রোগ্রাম করেছে।
ডক্টর আছেন আছেন ডক্টর সি আর চিত্তরঞ্জন সাউ, ডক্টর পান্নালাল সাহা, আমরা 1 মিনিটের একটা ব্রেক নিচ্ছি। আমরা ডক্টর আইএস রায়ের কাছে গিয়েছিলাম, স্যার অসুস্থ, গত সপ্তাহে পড়ে গেছিলেন।
14 জুলাই আমাদের অপথলমোলজিক্যাল সোসাইটি অফ ওয়েস্ট বেঙ্গলের প্রণাম অনুষ্ঠানে আপনার উপস্থিতি চাইছি।
আমি বার্ধক্যের জন্যে এই প্রণাম অনুষ্ঠানে হয়তো থাকতে পারবো না, যদিও চেষ্টা করব যদি কোনো রকমে এই লাঠি নিয়ে ধরে গিয়ে আমাদের অনুষ্ঠান সফল করি।
প্রণাম স্যার।
না,
ডক্টর দেবাশিস ব্যানার্জি স্যার আসেননি, আচ্ছা। ডক্টর দীপক চ্যাটার্জি, বেশ। ডক্টর দ্বিজপদ পদ দণ্ডপথ, ডক্টর দেবাশিস ভট্টাচার্য, দেবানন্দ কোথায়? ডক্টর দেবাশিস দত্ত, উনি তো নেই, ব্যাঙ্গালোরে আছেন। ডক্টর জীবনময় দে, ডক্টর জ্যোতির্ময় দত্ত, ডক্টর কাজল প্রসাদ ঘোষ, কাজল দা কই? একা কি করে নিয়ে যাবে, সঙ্গে দুজন থাকো। ডক্টর গীতেশ রঞ্জন ভট্টাচার্য, ডক্টর জ্যোতিকা পাল, ডক্টর মোহাম্মদ ইয়াসিন, এনো এনো, তুমি আগে এটা দাও, তারপরে ওটা দাও। এসছেন ডক্টর নারায়ণ চন্দ্র ঘোষ, ডক্টর মিতা খান,
সেই ওই বড় বাজারে ওই পোস্তার ওদিকে। হ্যাঁ এই তুই আয় না,
না না ছবি তোলো, ছবি তোলো, ছবি তোলো। ডক্টর প্রদীপ বক্সি, স্যার স্যার এনো নিয়ে যাও, নিয়ে যাও, আসছে, এমে যাচ্ছে। ডক্টর নির্মল নায়েক, ডক্টর মনোজ হাজরা, ডক্টর কমল কুমার সেনগুপ্ত, ডক্টর কাঞ্চন চ্যাটার্জি, ডক্টর গৌতম বিশ্বাস, ডক্টর প্রদীপ রঞ্জন চ্যাটার্জি, ডক্টর প্রদ্যোৎ নারায়ণ বিশ্বাস, ডক্টর পশুপতি সাহা, আমাকে বলে এখন আর লাভ নেই, আমি আউট অফ ট্র্যাক হয়ে গেছি। ওই রূপককে বলুন, রূপকের নাম্বার পাঠিয়েছি, হোয়াটসঅ্যাপ করে। ডক্টর রামকৃষ্ণ ঘোষ, ডক্টর রমেন্দ্রলাল সাহা, এটাকে নিয়ে যা, এটা নিয়ে যা, এটা নিয়ে যা, এটা নিয়ে যা আগে, এটা আগে নিয়ে যা, এটা আগে নিয়ে যা। এই ছবি না তো স্যার, আপনি এখানে চলে আসুন, মাঝখানে চলে আসুন, চলে যা, চলে যা। ডক্টর রীতা দাস, হ্যাঁ হ্যাঁ, এই না রীতা দি, রীতা দি। ডক্টর জেসি কুইলা, ডক্টর কুইলা, ডক্টর গৌর গাঙ্গুলি, হ্যাঁ স্যার, ডক্টর গৌর গাঙ্গুলি কে ফাঁকা আছে? ডক্টর শৈলেশ রঞ্জন দাস, ক্যামেরার দিকে তাকাও। ডক্টর সনদ চ্যাটার্জি, রূপক রূপক পরাগদারটা দাও সামনে। ডক্টর পরাগ মুখোপাধ্যায়, এই ডক্টর পরাগ মুখোপাধ্যায়, এটা নেই, এটা নেই। ডক্টর সমীর সেনগুপ্ত, স্যার প্লিজ স্যার।
যাচ্ছি 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 স্যার, স্যারের দিকে সামনে আরেকবার।
রূপক এদিকে। ডক্টর এস এন রয়, স্যার ছবি তুলুন। ডক্টর সুকুমার মণ্ডল, ডক্টর সুকুমার মণ্ডল, ডক্টর স্বপন সামন্ত, ডক্টর শ্যামল সেন, ডক্টর সমীর রয়, এটাই বড় কথা। ইয়ে দাও, বুকেটা দাও, বুকেটা দাও। ডক্টর শচীন্দ্রনাথ ধর, ডক্টর শচীন্দ্রনাথ ধর, ডক্টর শ্যামল পাণ্ডে, ডক্টর এস এন মিশ্রা, ডক্টর শেখরনাথ সরকার, শেখরদা, ডক্টর সুনীল মণ্ডল, না, ডক্টর উৎপল সিনহা চৌধুরী, ডক্টর শ্বেতকেতু ঘোষ, ডক্টর সমরেন্দ্র কাবাসী, ডক্টর পুষ্পিতা সাহু, ডক্টর পার্থপ্রতিম হাজারি, ডক্টর নীরজা রাটেরিয়া, ডক্টর অনিল কুমার পাল। স্যারকে দাও।
পরে পাঠিয়ে দেবো। শোন না অন্য একটা
হয়ে গেছে, হয়ে গেছে। ডক্টর সমীর রঞ্জন দত্ত, ডক্টর সমীর রঞ্জন দত্ত,
পাঠিয়ে দেবো আজকে ছবিটা, ঠিক আছে
ওকে। আর এটা আছে কি নাম? পিছিয়ে যাবেন, একটু পিছিয়ে যাবেন।
ডক্টর ডিসি পান, আসুন।
এটা আমরা পাঠিয়ে বাড়িতে এটা পাঠাতে হবে। এখন স্যারকে দিয়ে রাখো।
কাজলদার একটা আবৃত্তি আছে, আমি কাজলদাকে অনুরোধ করব কাজলদার আবৃত্তিটা করতে। আমি জাস্ট একটু বলে দিই, একটা গ্রুপ ফটো উঠবে কাজলদার আবৃত্তির পরে, তারপরে আমাদের নাটক শুরু হবে।
বিশ্বকবি রবীন্দ্রনাথের আফ্রিকা। উদ্ভ্রান্ত সেই আদিম যুগে স্রষ্টা যখন নিজের প্রতি অধৈর্যে নূতন সৃষ্টিকে বারবার করছিলেন বিধ্বস্ত, তার সেই অধৈর্যে ঘন ঘন মাথা নাড়ার দিনে রুদ্র সমুদ্রের বাহু প্রাচী ধরিত্রীর বুকের থেকে ছিনিয়ে নিয়ে গেল তোমাকে আফ্রিকা। বাঁধলে তোমাকে বনস্পতির নিবিড় পাহারায়, কৃপণ আলোর অন্তঃপুরে, সেখানে নিভৃত অবকাশে তুমি সংগ্রহ করছিলে দুর্গমের রহস্য, চিনছিলে প্রকৃতির দুর্বোধ সংকেত। আপনাকে উগ্র করে বিভীষিকার প্রচণ্ড মহিমায় তাণ্ডবের দুন্ধুবি নিনাদে। হায় ছায়াবৃতা কালো ঘোমটার নিচে অপরিচিত ছিল তোমার মানব রূপ উপেক্ষার আবিল দৃষ্টিতে। এর লোহার হাত করি নিয়ে নখ যাদের তীক্ষ্ণ তোমার নেকড়েছে, এলো মানুষ ধরার দল গর্বে যারা অন্ধ তোমার সূর্যহারা অরণ্যের চেয়ে। সভ্যের বর্বর লোভ নগ্ন করল আপন নির্লজ্জ অমানুষতা। তোমার ভাষাহীন ক্রন্দনে বাষ্পাকুল অরণ্য পথে পঙ্কিল হলো ধুরি তোমার রক্তে অশ্রুতে মিশে। দস্যু পায়ের কাঁটা মারা জুতোর তলায় বিভৎস কাদার পিণ্ড চিরচিহ্ন দিয়ে গেল তোমার অপমানিত ইতিহাসে। সমুদ্র পাড়ে সেই মুহূর্তে পাড়ায় পাড়ায় বাজছিল পূজার ঘণ্টা, সকালে সন্ধ্যায় দয়াময় দেবতার নামে। শিশুরা খেলছিল মায়ের কোলে, কবির সঙ্গীতে বেজে উঠছিল সুন্দরের আরাধনা। আজ যখন পশ্চিম দিগন্তে প্রদোষকাল ঝঞ্ঝা বাতাসের রুদ্ধশ্বাস, যখন গুপ্ত গহ্বর থেকে পশুরা বেরিয়ে এলো, অশুভ ধ্বনিতে ঘোষণা করলো দিনের অন্তিম কাল। এসো যুগান্তের কবি, দাঁড়াও ওই মা ধারা মানবীর দ্বারে, বলো ক্ষমা করো হিংস্র প্রলাপের মধ্যে, সেই হোক তোমার সভ্যতার শেষ পুণ্যবাণী। নমস্কার।
যতবার কাজলদার আবৃত্তি শুনি ততবার আপ্লুত হয়ে পড়ি। অসাধারণ আবৃত্তি, কাজলদার নিয়মিত চর্চা করেন। একটা গ্রুপ ছবি, যারা এখানে উপস্থিত আছেন সকলে মিলে একসঙ্গে হলে তারপরে আমরা নাটকটা শুরু করে দেবো।